Hello and welcome everyone to the continuation of our course on resistance medicine, which includes action, street, protest, and riot medicine, but also just medicine for our communities, because medicine is freedom. This is part of both the resistance medicine course and also the herbalism for activism course, because we kind of threw them both together and merged them. As we went over in the legalities, it is more legal for medics to make use of herbal remedies than it is for them to make use of allopathic remedies. However, for wound care, we are going to be talking about a lot of allopathic medicine, because generally Good Samaritans are allowed to use tools out of allopathic medicine to stop someone from bleeding to death without needing to worry that a court's going to go after them. But you still can't hand out Tylenol or ibuprofen. So where exactly the line is drawn is a little complicated. Anyway, I digress. Let's introduce ourselves, because we have some new students, and then we're going to get into the scope. Sanctum of the Craft is an anarcho-socialist witchcraft collective, medic collective, seminary, online school for witchcraft. You don't have to be a witch to make use of any of our content. We welcome people of the entire spectrum of spirituality and religion, from atheist to deeply spiritual in faith that don't generally approve of witches. We don't care. We just want our community to be informed about a lot of things in an era of misinformation and disinformation. This is one of them. Today's class is primarily taught by myself. I am a trained medic, herbalist, midwife. I've been through trauma training, first aid certifications, all kinds of trainings, but I am not an allopathic practitioner. I am not an EMT, an emergency medical person, and I am not a surgeon. Okay. There are medic classes currently being offered in Durham a couple times a month that are being taught specifically by medical professionals, like EMTs, nurses, physicians. Their classes are great. I highly recommend you check them out. Ideally, I think that you should be learning from a spectrum of people and attending as many medic classes as you can. So try and make it to theirs and ours, ideally. That would be great. The other person here representing Sanctum of the Craft is Jan, my partner. He's primarily tech, which I know is a dramatic oversimplification of everything you do, but that's what I'm going to say for now. Okay, let us move on. So I want to talk to you about scope really quick, and I don't have a slide that goes for this. This class is thorough. This class goes over a lot of information, and one of the reasons it does is because I got angry at a lot of other medic trainings that I attended, a lot of other medic things I downloaded and read, and I went through so many books on prepper medicine, wilderness survival, a spectrum of first aid books when I was assembling this class. And a lot of them made me really, really angry because they were full of either incomplete information, misinformation, or just flat out disinformation. And I believe that some of the sections in those guides and books are going to get people killed. People are going to die, and that pisses me off. So I got thorough, which tends to be my response to misinformation and disinformation, is to just info dump the correct information. The way that this class is structured, just so y'all are aware, is that we're going to start really basic with stuff that normally we would have addressed in previous street medic classes. We normally start with the ethics, the legalities, the scope, and then we get into the systems of the body and the way the body works and healing and how drugs affect the body and etc. We moved this up because people were getting injured while doing mucking and gutting efforts in response to the floods. People were getting lacerations and abrasions, so we moved it up. Unfortunately, that means that the beginning of class is going to go over some basic review we normally would have taught you by now. Then we're going to get into the super basic wound care model. This is exactly what a medic should do. Then we're going to get into specific ways that applies to the body. And then we're going to get into more complicated topics, like what happens if they're bleeding more heavily than that? What happens if it goes wrong and there's gravel or wood in the wound? What happens if the wound gets infected? Okay, so that's the system. If at any point you need to leave because it's just taking too long, by all means do so. This is getting recorded. It will be posted on YouTube. It will be posted in our free and public area on our Patreon. And the notes are available via a QR code on the tables there if you just want to read it for yourself. All right.
I'm going to add one additional disclaimer. We did our best to make the images on these slides relatively non-graphic. However, this is a class on wound management, which means that there is some blood, there are some wounds.
And if you Google any of these topics yourself, like let's say you Google images of degloving injuries, you're going to find a lot more graphic images than we chose. We tried to pick the least traumatizing images we could find that still conveyed the information, and to go with illustrations whenever possible. But, so, if you have a weakness to blood, the images in this class might be a little bad for you. But I also think that if you've got a weakness to blood, maybe be medic support, not a medic. That make sense? Cool. Let's get into it. The skin is the largest organ in the human body and the body's largest interface with the external environment. Because it is one of the primary ways that we interact with the world, it is also frequently injured. A wound is any injury to the soft tissues of the body, which are the non-rigid, non-bony tissues that connect, surround, and support the body's organs and structures. This includes the skin, muscle, tendons, ligaments, fat, fibrous tissue, lymph and blood vessels, fascia, synovial membranes. All of that is soft tissue, excepting hard tissues, which are bones and teeth. Okay? Those are hard tissues. An injury to the skin with or without involvement of any of the subcutaneous tissue and muscle is referred to as a soft tissue wound. The human skin, the integument, is part of multiple systems of the body. It actually belongs in multiple systems, not just its own system. It's part of the excretory system, which consists of the kidney, the large intestine, the liver, the skin, and the lungs. Excretion is the process of removing waste and excess water from the body, which is one of the major ways that the body maintains its homeostasis. Although the kidneys are the main organs of the excretory organ, several other organs also excrete waste. The skin eliminates excess waters and salts. If you have ever been sold something that claimed it was detoxifying your body, no, it wasn't. Your body does that already. It does it itself. It does not need you to drink any lemon water or turmeric ginger shots to detoxify itself. That's what your kidneys are for. Maintaining kidney function is how you detoxify your body, and the skin is part of that system. It is also part of the immune system, specifically as part of the innate rather than the acquired immune system. The innate immune system is inherited and active from the moment of birth. It's the one that you are born with. The adaptive immune system is developed when a person's body is exposed to microbes and chemicals released by microbes. The innate immune system is the body's rapid response system. It consists of the skin, the eye's cornea, and the mucous membranes that line the respiratory, gastrointestinal, and genitourinary tracts. These act as the physical barriers that help to protect the body from harmful germs, parasites, and cells. When this system recognizes an invader, the cells of this immune system surround and cover the invader and kill it inside the immune system cells. The skin is the primary organ of the integumentary system, also called the exocrine system. This consists of hair, scales, feathers, hooves, nails, and all the appendages thereof. The integumentary system is the set of organs that form the outermost layer of an animal's body. It acts as a physical barrier between the external environment and the internal environment, and it regulates all exchanges with the outside world that don't go through the lungs. Okay? It has a range of additional functions. It maintains water balance and salt balance via sweat. It protects deeper tissues from damage. It excretes waste. It regulates body temperature. And it is the attachment site for the nervous system's sensory receptors that detect pain, sensation, pressure, and temperature. The skin is the body's first line of defense against pathogens, harmful substances, injuries, and more. The skin's inflammatory response to injury is part of how it responds to injuries and wounds. The blood vessels dilate so that fluids can get to damaged tissues with the necessary nutrients and oxygen so that those wounded tissues can heal. The integumentary system controls the heat and the water the body loses to its environment via sweat and goosebumps. The tightening of the skin raises fine hairs upright, which traps warm air close to the skin. The skin is also where vital biochemical processes occur, including the synthesis of vitamin D and the production of some proteins, lipids, glycans, signaling molecules, and immune cells. The skin is a very complex organ that scientists have not yet been able to adequately reproduce artificially. They have not made artificial skin that works anywhere near as good as our skin does. It's a dynamic tissue. It goes through constant changes, contributed to by the circulatory system underneath the skin and by a number of glands on the outside of the skin, which secrete oils and other substances that keep the skin from drying out and cracking. Significant wounds to the skin may make a person not only vulnerable to microbial infection, but also to temperature instability, disturbance of fluid balance, and loss of mobility. This is why if you get enough burns on your body, it is a really, really big deal because it compromises all of those systems. Anatomy of the skin and the fascia. The skin and fascia are complex with many important anatomical features. However, in an effort to keep this as brief as I possibly can, we're going to focus on the anatomy that is relevant for the treatment of wounds in a non-surgical environment. You don't need to know exactly where certain nerves are because you are not going to be performing surgery, unless some of you are surgeons. I don't know, you might be. The layers of the skin and fascia include the epidermis, the dermis, the superficial fascia, commonly referred to as the subcutaneous or subcuticle layer, and the deep fascia. These layers are planes that may be disturbed by physical trauma and need to be back in alignment for proper healing to take place. This is why they really carefully line up your wound edges when they're doing something like sutures. The demarcation between the epidermis and the dermis is not visible to the naked eye. You cannot, as a medic, even with a magnifying glass, look at someone and be like, this is where their dermis ends and their epidermis begins, or vice versa. You need a microscope to do that, or like better magnification, okay? Moving on. I'm sorry, I lost my place. The epidermis is the outermost layer. It consists of the squamous epithelial cells with no nerve endings, blood vessels, or other organs beneath it. It primarily serves to protect against microbial ingress, harmful chemicals, and radiation, and to maintain water and electrolyte balance in the body. It is the outermost visible layer of the body, and it's only a few cell layers thick. If you have ever had your skin flake off after a sunburn, that is actually doing its job to protect you from radiation. The demarcation between the epidermis and the dermis is not visible to the naked eye. Understanding where the epidermis ends and the dermis begins has to be done by approximation. The dermis is the layer immediately beneath the epidermis. It's much thicker. It primarily consists of connective tissue. The main cell type in the dermis are the fibroblasts. Fibroblasts contribute to the formation of connective tissue, a fibrous cellular material that supports and connects other tissues and organs in the body. They secrete collagen proteins to help maintain the structure of tissues in the body. Fibroblasts also play an important role in the healing of wounds. The deeper dermis also contains the majority of the important skin structures, also called skin appendages or adnexa. This includes your hair follicles, your sebaceous glands, your sweat glands, and a network of interconnected blood vessels, typically capillaries, that form a mesh-like structure within a tissue or organ called the vascular plexus. This is also where nerve fibers start to branch and differentiate as they move upwards towards the upper layer of the skin. Damage to the dermis is more serious than damage to the epidermis. Extra effort has to be made to properly cleanse injuries, remove debris, and close the edges of dermal wounds to allow for wound healing. Some dermal wounds will require stitches. Below the dermis is another layer. This is the superficial fascia, also called the subcutaneous level. This consists of loose connective tissue around fat. Injuries that reveal recognizable fat have penetrated the epidermis and the dermis to this level. Wounds through this layer promote bacterial growth and infection, and any debridement to remove foreign material may leave behind a dead space, which can lead to abscesses. Any foreign material left behind in this space also leads to an increased risk of infection. So these are harder to clean out, they're harder to prevent from getting infected, and most of the time they're going to require professional medical assistance. So like something from an EMT, emergency medical services, emergency department. Okay? Let's see. Beneath the superficial fascia is a layer of deep fascia, which is thicker, denser, fibrous type of tissue that acts as the base for the superficial fascia and the enclosure of all muscle fibers. It provides support and protection for muscles and other soft tissues and acts as a barrier against infection that is spread from the skin so that it doesn't actually penetrate into the muscle. You do not want a muscle infection. This layer can be visibly recognized as an off-white sheath over and around muscle tissue. Wounds to the deep fascia are recognizable and of more significant concern as they damage the protective and supportive functions of that layer. And if they penetrated the deep fascia into the muscle, that is of serious concern. So if you're looking into a wound and you go, okay, skin, fat, sheathing over muscle, that's muscle with no sheathing. We're talking emergency services. Everyone clear? Okay. A wound this deep will require professional medical closure, although in some cases deep wounds in this area cause too much tension and cannot actually be closed, even by someone doing sutures, someone doing stapling. They have to let it heal from within, keeping it free from infection, and then close it later once it's come up to a certain point and filled itself in. Everyone make clear on what I mean by that? Okay. Tension lines. The skin is arranged on people in patterns. These provide tension and tautness. The tissues lie in what is referred to as tension lines. Wounds that are parallel to the skin tension may stay closed on their own much more easily and not require closure by something like Steri-strips, zipper wound closure strips, biodegradable glue, stitches, or staples. But even small wounds that cross the skin tension lines in perpendicular fashion can stay open and refuse to close. Healing is very slow in an open wound. It is more likely to risk infection and more likely to form abnormal scar tissue. Areas with very little movement, like the scalp, have what's referred to as static tension, where the skin isn't really moving around all that much and it tends to stay closed pretty easily. Areas that have a lot more movement, a lot more muscle contraction, or that are really affected by gravity, like breast tissue, those areas have a lot harder time staying closed because of those factors pulling on them, and they are referred to as having dynamic tension. Injuries in areas with increased dynamic tension may heal more slowly due to repeated movement. Wounds that lie perpendicular to tension lines on dynamic tension areas tend to close the most slowly because the clotting process and tissue repair cycle are constantly being interrupted. Medics should take into account skin tension when determining how serious a wound is and whether or not to seek emergency medical services. Physicians repairing wounds also have to take into account skin tension lines when closing a wound, because if they close it inappropriately across those tensions, it just rips back open. Okay. Everybody good on that? Let's move on. Kinds of soft tissue wounds. The soft tissues of the body can be injured in many ways. A blunt injury refers to tissues being injured by an energy exchange between a person and a blunt object. This is like when you hit a stool with your toe or your shin and you're like, ow, fuck, but it didn't actually cut you. That's a blunt injury. So is hitting your head on a steering wheel in a car crash. A penetrating injury occurs when an object actually breaks the skin and enters into the body, creating an entrance wound and sometimes an exit wound. The object can be a splinter, a knife, a bullet. Yes.
If the skin is ripped due to blunt impact, which one does that fall under?
That would be an external open injury to the soft tissue, but not a penetrating injury. Okay? Of the soft tissue injuries are the most common form of injury. Care for superficial wounds to the soft tissues, abrasions, lacerations, bites, burns, etc. is the second most commonly performed procedure in emergency departments in the United States, following intravenous line insertion. Of those who seek emergency services for soft tissue injuries, 74% were identified in records as male. Doesn't mean that they actually were male, but they're identified in the records as male, with an average age of 23. The average laceration was 1 to 3 centimeters. Only 13% were considered significantly contaminated. 51% of the wounds occurred on the face and scalp, 34% on the upper extremities, and 13% on the lower extremities. Now, this is people who sought emergency care. This doesn't mean that it's the most common soft tissue injury. The most common soft tissue injuries that people receive are small injuries to their hands and feet as they just go through their day. You get a blister, you don't generally go to the emergency room. You nick your finger with a kitchen knife, you generally don't go to the emergency room. This is the most common serious lacerations and avulsions. Everyone, and abrasions as well. The most common complication of emergency wound care was infection, with approximately 3.5% to a little over 6% of laceration wounds treated in the emergency department becoming infected. The rate of infection in children was much lower, only a little over 1%. Death due to soft tissue injury is extremely rare these days. There was a time in history where these could kill you very easily. Now, with better access to allopathic medicine, death due to soft tissue injury is pretty rare. When it happens, it's generally due to either severe hemorrhage or severe infection. So what's a hemorrhage? Hemorrhage just means bleeding. That's literally all it means. It doesn't mean severe bleeding, it doesn't mean minor bleeding, unless you have a clarifying adjective in there. Hemorrhage just means bleeding. A hemorrhage can be caused by a small nick to a capillary while cooking or shaving that beats up a single drop of blood. But it can also be caused by a deep stabbing with a knife, a gunshot wound, or a ruptured organ from striking or being struck by a blunt object. Movies often use this term hemorrhage only to describe heavy bleeding. Raise your hand if as a kid you thought hemorrhage meant like heavy bleeding, because that's how it's used in TV or movies. Hey! Yep. It doesn't mean that, just means bleeding. Okay, but I did too. I thought I did too. I really confused my grandmother. Hemorrhage can be external and thus visible, or internal and thus not visible. Most external hemorrhage can be controlled by direct, even pressure, although some may require more drastic interventions. Steri strips, zipper wound closure strips, hemostatic dressings, pressure dressings and or splints, tourniquets, wound packing, tissue bonding, biodegradable glue, stitches, staples, etc. How severe an external hemorrhage is relates to the type of wound and what types of blood vessels have been injured. In general, hemorrhage from a capillary oozes. From a vein, it flows, and from an artery, it spurts. But this isn't infallible. A large abrasion, like road rash, can cause considerable flowing, more than oozing, from a lot of cut capillaries. Arteries that are cut directly across or transversely may recoil, and they slow their own bleeding, and they never spurt. If a person is near exsanguination, the artery will also likely not be spurting anymore because their blood pressure has decreased so much. Exsanguination is the loss of the total blood volume, and it causes death. So at that point, if someone's artery has stopped spurting, that is not a good sign. Capillary bleeding is generally bright or dark red blood. Venous bleeding is darker, and arterial bleeding is usually bright red because of the fully saturated hemoglobin. But in reality, most large wounds have a combination of arterial and venous bleeding, so the differentiation by color isn't actually possible. The few times I've been in a situation where I was dealing with arterial bleeding, there was not a color differentiation that made it clear that there was arterial bleeding. It was spurting, which is how I knew it was arterial bleeding. Anyway, also the depth was kind of a clue, and knowing where arteries are. Anyway, some extremely severe injuries may not bleed much at all, such as when an amputation also involves cauterization of the wound, so there just isn't much bleeding, while other less severe injuries may bleed significantly. Minor cuts to the face and scalp bleed a lot, but they generally aren't that serious. Internal hemorrhage can occur in any part of the body. Some internal hemorrhage isn't serious, heals on its own, such as when a fracture to a bone damages a few blood vessels and a little bleeding occurs in the area. Internal hemorrhage can be caused by trauma, falls, crushing injuries, blunt force impact, penetrating wounds, etc., or by non-traumatic medical issues. Gastrointestinal bleeding, ruptured ectopic pregnancies, ruptured aneurysms. Non-traumatic, as in not caused by a traumatic fall or a car accident, etc., does not mean not serious. Symptoms of internal bleeding include, but are not limited to, pale or gray skin, hematomas, which is a solid swelling of clotted blood, dizziness, lightheadedness, fatigue, weakness, shortness of breath, increased breathing rate, tachycardia, nausea, vomiting, confusion, presyncope, which is feeling like one is about to faint, syncope, which is fainting, seizures, loss of consciousness, and hypovolemic shock. We're going to get into more on that later. If the injury is to the head, the symptoms may include thunderclap headaches, changes in vision, confusion, and weakness on one side of the body. If the injury is to the chest, the symptoms may include difficulty breathing, chest pain, and coughing up blood. If the injury is to the abdomen, the symptoms may include swelling, feeling full, bruising, blood and vomit, urine or feces, inappropriate bleeding from the vagina, outside of the appropriate place in the menstrual cycle, or way too heavy. If the injury is to the bones, joints, or muscles, the symptoms may include bruising, swelling, and pain. If a person a medic is assisting presents with the signs of severe internal hemorrhage after a bad fall, a crushing injury, being stabbed, they should be treated for shock while emergency medical services are called. It is better to assume internal bleeding than assume the otherwise and get it wrong. Yes?
What are thunderclap headaches?
It feels like lightning struck your head. Everything just whites out. It feels like there should be, have any of you ever been struck in the head and gotten a concussion? Hey, I got some hands up. Me too. So that sensation, where just it's like someone hits you in the head with a hammer and it just keeps whom, whom, whom. The worst headache you've ever gotten and it doesn't stop. Okay. Types of wounds. A closed wound is one in which the soft tissues beneath the skin surface are damaged, but there's no break in the skin. Most closed wounds are contusions. This is also called bruising. In a contusion, the skin isn't broken, but damage to the tissue still produces pain, leakage of fluid between damaged cells, and an inflammatory response. The inflammatory response results in redness, erythema, and swelling, erythema, and swelling, edema. If small blood vessels in the dermis are broken, a mark, ecchymosis, that looks blue and black may appear. If larger blood vessels in the dermis are broken, a collection of blood beneath the skin may appear, called a hematoma, which looks and feels like a lump with blue, purple, and red coloration. Closed wounds can be mild bruising, but they can also include more serious non-penetrating blunt trauma to important structures. A person with a closed wound where a lot of blunt force was relayed to organs or bones may require medical attention. Think car accident, heavy boxes falling on someone. An open wound involves a disruption in the skin and can include cutting and penetrating injuries. These include abrasions, lacerations, avulsions, bites, punctures, injections, and serious penetrating wounds like gunshots. Open wounds are typically more vulnerable to infection than closed wounds. An abrasion is a wound where the skin is rubbed or scraped, and friction is what causes the injury. A superficial abrasion is only to the epidermis, but a deeper abrasion may be to the dermis or deeper and be a more serious injury. Anything from a carpet burn to road rash would still be considered an abrasion. So think, I fell as a kid on the sidewalk and I skinned my knee a little bit. That's an abrasion. But so is I fell off my motorcycle and skipped down the road and left significant portions of skin on the way. Also an abrasion. They can be very minor, they can be very serious. A laceration is a cut inflicted by a sharp instrument or by blunt force that tears the tissue. So you can get a laceration because you cut your finger with a knife, but you can also get a laceration because a heavy box fell on your foot and it split the skin. That split in the skin is the open injury, and then beneath it would be a crush injury or a contusion, okay? Depending upon the severity. Deep lacerations can cut veins and arteries, causing severe bleeding and risk of death. More on this when we get into hypovolemia and hemorrhagic shock. Deep lacerations can cut tendons. Even if a tendon is only half lacerated, it can rupture the rest of the way within 48 hours of being cut. Lacerated tendons are sometimes visible to the naked eye, but sometimes not. A person may also not be able to tell a medic that a tendon has been affected in order to, do anything about it. They may not even notice until it actually snaps. An avulsion, also referred to as a degloving injury, occurs when a flap of skin is torn loose, either partially or completely. This can happen with an abrasion or a laceration or in conjunction with other wounds. It's very common in bites. The amount of hemorrhage and danger from an avulsion relates to both how much of the skin is lost and the depth to which the skin is lost to. Degloving injuries can be really minor, such as again when a person skins their knee on a bike, or very serious, such as in road rash, car accidents, or work accidents with machinery. Large areas of lost skin must be addressed by emergency services. Sometimes skin is ripped away so deeply that the wound goes down to muscles, tendons, connective tissues, and even bones. It's called a degloving injury, an avulsion is, because it's like you took off a glove, and it's your skin. It can be a tiny patch. I don't know if any of you have ever skinned your knee to the point where a little flap of skin came up as a kid. That's an avulsion rather than an abrasion, although they're often in conjunction with each other. You often have an abrasion and an avulsion. But it could be something serious like when an airbag takes all the skin off someone's arm. That can happen if you hold your steering wheel inappropriately. Okay. More serious wounds that are beyond the scope of this class. I'm putting them in here so you know that we will get to them eventually, but we're not getting to them today. Puncture wounds, also called penetrating wound, is when the soft tissue injury is from a piercing object. That piercing object can be anything from a splinter to a bullet. Puncture wounds can be deeper than they first appear and damage underlying structures within that aren't immediately apparent to a medic. They may not bleed heavily and still have damaged internal structures to a dangerous level. If a puncture wound is deeper than the upper dermis, it is worth seeking medical attention for, even if there's very little external bleeding, because they're way more prone to infection. An amputation is an avulsion injury, a degloving injury that involves the partial or complete loss of a body part, which is generally a finger, toe, hand, foot, arm, or leg. A partial amputation is characterized by some soft tissue remaining attached, A complete amputation is characterized by no soft tissue connecting the cutaway piece from the rest of the body. Amputations may also fracture bones. Severe hemorrhage from complete or partial amputation is life-threatening, which is one of the reasons why I recommend all medics carry a tourniquet. Bite wounds are soft tissue injuries caused by bites from animals, including other humans. The mouths of any animal can be heavily contaminated by bacteria. Cat bites, for example, are extremely dangerous. The human mouth contains an even larger range of bacteria or viruses than a dog's or cat's. Additionally, bites can be mangled, mutilating wounds that are complicating to repair. Any bite wound that penetrates the skin should be considered a serious injury. I'm not kidding. If a stray cat bites you, you need to go to a doctor. Okay. High-pressure injection injuries are caused when a foreign material is injected into soft tissues, which most often happens while working with tools and machines or in car accidents. That material may be air, water, grease, paint, etc. Even a small injury may be dangerous depending upon what the foreign material is that got injected into someone. A crush injury is caused by compressive force, which can happen in car accidents, work accidents, while rock climbing, etc. The compressive force may crush portions of the body, cause hemorrhage or even amputation, impair metabolism and circulation, and cause systematic and systemic problems. The longer a portion of the body remains crushed, the worse the danger is to the person. If an extremity has been crushed for longer than 4 hours, it can lead to crush syndrome, where it is dangerous to release the crushed extremity due to metabolites building up in the crushed tissues. When released back into the uncrushed tissues, they can cause harmful effects and even lead to organ failure. Minor crush injuries will be addressed in our later guide on bruising and contusions, but more severe crush injuries are addressed in our guides on wilderness crisis preparedness, which we're not teaching at RUMA at this time. Because that's like someone has been crushed and you don't have emergency care coming for several hours. How do you keep them alive? Anyway, blast injuries are caused by explosions and include a spectrum of other types of injuries, including concussive trauma to the body, as well as soft tissue wounds from flying materials, hard tissue injuries like broken bones, respiratory trauma from inhaled materials, etc. We may choose to eventually address blast injuries in our upcoming guide on preparation for fires, but we've yet to determine if that's actually in scope or I'm doing the thing where I'm preparing people for unlikely scenarios. I'm going back and forth on it. Understanding wound healing. Any questions on why I ran through those kinds of injuries and what we are and are not covering today? Okay. Wounds heal in several overlapping stages that the body undergoes with the aim of restoring homeostasis. Ultimately, it's the body's function to survive. A body's survival is dependent on its ability to maintain and restore homeostasis. I have used this word several times. Let's define it. Homeostasis is the stability, balance, equilibrium, and relative constancy within an organism, from a single-cell organism to the entire human body. Etymologically, homeostasis descends from two Greek words, homeo, meaning the same, also the root for the word homosexual, and stasis, meaning standing. Standing or staying the same is the meaning of homeostasis. An organism must maintain a relatively consistent internal environment. Keeping a stable internal environment involves constant adjustments as conditions change inside and outside every single cell in the body, all the way up to the entirety of the body itself. The constant fluctuation and adjustment of body systems to maintain homeostasis is referred to as homeostatic regulation. Because the internal and external environments are constantly changing, whether looking at an individual cell or an entire body, adjustments have to be made constantly and continuously. Homeostasis is dynamic, it's fluid, it isn't rigid, it's flexible, it's changing, it's relatively adaptable. But ultimately, the goal is for the body to return to a functional, survivable state, which doesn't mean that an injured area returns to its pre-injured condition. Any of you ever get an injury that just never healed quite right? It happens. It doesn't necessarily return you to your pre-injured state, it just keeps you alive, if it can. The first of 4 stages of wound healing is referred to as hemostasis, not homeostasis, hemostasis. This has caused some confusion in students before. This is blood standing still, if you're looking at the root words. For a wound to heal, first it has to stop bleeding. Loss of blood affects the body's homeostasis, so the body begins the healing process by restricting that flow of blood. This is done via the clotting cascade, which is the first stage of this healing and the first stage of something called vasoconstriction. During the hemostasis stage, arteries, arterioles, and some veins have muscular layers that can constrict, and they reduce the blood loss. Capillaries lack smooth muscle, so bleeding continues seeping from them for longer but isn't as serious. Platelets are also released during this stage, which form a plug that temporarily stops the loss of blood and begins the blood clot formation. The second of the 4 stages is inflammation, during which additional cells move to the damaged area. Chemostatic factors, substances that attract cells like leukocytes and macrophages to a specific location, are released in response to stimuli like tissue injury and infection, and they guide cells to the site of the problem to initiate or enhance the immune response and begin tissue repair. White blood cells move to the area to combat bacteria, viruses, etc. Granulocytes and macrophages, restoration cells, they all engulf bacteria and ingest damaged cellular parts. Mast cells also release histamine, which then dilates the previously constricted blood vessels, increasing blood flow to the injured area and resulting in that reddened, warm area that you get after you're injured. Yes. Thank you. Histamine also makes capillaries more permeable, which then causes swelling as fluid starts seeping out of those swollen capillaries. Inflammation causes the removal of foreign material, pathogens, and damaged cells, and the beginning of the healing process. Proliferation is typically listed as the 3rd phase of healing. This is slightly misleading, as it's actually an ongoing set of processes that are occurring continuously, including during the initial 2 phases. However, there is a distinct period after the end of the inflammatory stage and before the beginning of the maturation stage, during which it is the only primary process occurring. Therefore, this is where it's typically placed. Proliferation involves the formation of new tissue, and this includes the following. Epitheliation, during which new epithelial skin cells are moved to the area and begin reconstructing the skin from the edges of the wound inwards. Have any of you ever looked down at a wound and there's like a matrix of white lines forming on it, kind of creeping towards the center? That's epitheliation. That's that first stage of this. Then there's neovascularization, during which new blood vessels form. New blood vessels, especially capillaries, are very fragile. So sometimes this results in additional bleeding. If you had a wound and it sealed up and it got a clot on it, and then the scab fell off, and then it kind of wept blood for a few days in there before it eventually closed up, that's because the neovascularization stage is very, very fragile. Wounds are very easy to re-injure during this stage. Then formation of granulation tissue, a weak but quickly forming variety of collagen, creating a cellular matrix that allows for the skin cells, immune cells, and epithelial cells to have a structure to grow on. That's that white matrix that's forming over the wound. The 4th stage of wound healing is known as either the remodeling or maturation stage. They refer to the same thing, but some people use one term or the other. During this stage, full collagen synthesis occurs. Collagen is vital to the structures of the body. It's a tough, fibrous protein found in skin, hair, bones, connective tissue, and scar tissue. It is synthesized by the fibroblasts and stabilizes the damaged tissue, allowing for it to close. Collagen cannot restore damaged tissues to their original strength, and it's very weak in the early healing stages. About 2 weeks after a wound has closed, during the proliferation phase, it has only about 5% of the skin's original tensile strength. In about a month, it has about 35%. Its final tensile strength will not be achieved for months and will typically be approximately 80% of the strength of the original tissue. It will never be as strong as it was before it was cut. This is a myth. The whole scar tissue is stronger. No, actually it isn't. And anybody who ever told you, it's okay that that horrible thing happened to you because you're stronger for it, is an asshole. Okay. Moving right on. Let's move out of the super basic information to the more relevant things to acting as a medic, starting with what's referred to as scene assessment. Before I do so, any questions on that information or why I included it? All right. Anybody learn something new? Hey, I got some nods. We teach an entire class on scene assessment and threat modeling for street medics. This is the shallow version. This is the hopefully in a couple minutes version. Anytime a medic encounters a person whom they intend to assist who has become injured, they should assess the scene before they move to assist. This can be done very quickly, but it's a vital self-protection step that also ensures that they will be able to help the person that they want to help. Although bleeding injuries can appear significant and frightening, most are relatively non-threatening. They are rarely going to be the immediate cause of someone's death, although there are exceptions for massive and severe hemorrhaging and or injuries that compromise an airway. The first aspect of scene assessment is safety. They need to check if it is safe for them to approach, if it is safe for the person who is injured to remain where they are, and if the danger is to others present in the area as well. They need to check for environmental conditions that would make it unsafe for them to enter into the scene. The danger of more falling objects, fire, increasing floodwaters, rapidly speeding by traffic, all of that has to be taken into account when you enter a scene to help someone. If the scene is unsafe, they need to check if there's anything they can do to make it safe. If there's a fire, can they put it out? If there's traffic speeding by, could they put out flashers or flares to redirect traffic? A medic should not enter the scene if it will endanger their life to do so. If the scene is not safe and there is a way to call for additional help to make it safe, the medic should do so as quickly as possible and provide assistance as soon as they can. Another aspect of safety is exposure to bloodborne illnesses. Skin injuries may result in the medic being exposed to blood and other bodily fluids. Depending on the severity of bleeding, a medic may need to use gloves, a mask, or an eye shield, or all of the above. The medic should avoid contact with bodily fluids to any open wounds on their own body and to their mucous membranes. Again, we teach an entire class on blood safety and gloving up and all of that, including how to actually appropriately get on gloves. But this is focusing primarily on other topics. If there is no other option and the wound is life-threatening, the medic may have to assist a bleeding person without adequate protective equipment. If the medic is exposed to blood from the person they are assisting and the person has an unknown medical history, so this is not their child, their spouse, their partner, their parent, etc., they don't know, they should, as soon as possible, clean the affected area with soap and water, flushing their eyes, nose, and mouth with water or sterile saline. Then they should report that exposure to medical professionals and receive a medical evaluation, possibly including blood tests for both them and the source person to determine risk and potential necessary follow-ups. For example, they might be given post-exposure prophylaxis, PEP, a medication that can significantly reduce the risk of HIV exposure and HIV infection. Okay, assessment of the injured person. The first step to assessing the bleeding person is to make sure there's no immediate threat. The medic should assess the person's mechanism of injury next, which refers to how the injury occurred, the forces involved, and the potential severity of that injury. In cases of a minor injury, such as a nick from a kitchen knife or a scraped knee, this assessment's pretty simple. How was the person injured? They cut their finger slightly while chopping, they slipped off their bike and they scraped their elbow, etc. The injury may not be severe enough to cause more complex symptoms, and the assessment can proceed to how to manage the injury. In cases of more severe injury or injury from an unknown cause, the assessment is more complex. This can occur if someone has hurt themselves more severely, wider, deeper lacerations, or if the soft tissue injury is complicated by more complex injuries, like it was caused by a fall, a car accident, a falling object, and thus involves contusion, concussion, crush injuries, compromised airways, etc. The medic should rapidly assess if the injured individual is in an altered state of consciousness, if they have compromised breathing, or if there's uncontrolled heavy bleeding, if they are exhibiting signs of shock, or if they are unconscious. This should be done by checking the person's airway, breathing, circulation, disability, and exposure. These are referred to as the ABCDEs, to determine if the person is alert, responsive to verbal stimuli, responsive to painful stimuli, or completely unresponsive. This assessment should determine if there is immediate life-threatening injury, including potential brain injury or impaired circulation to the brain. Some medics use a small c at the beginning of the ABCDEs to refer to critical bleeding, or an X for extreme bleeding. If someone is in immediate danger of bleeding to death, the rest of the assessment can wait while that is being addressed. If someone is bleeding out from a spurting artery, you have approximately 2 minutes to save their life. So if someone has extreme bleeding, that's first. Everything else can wait. If the person is pale and ashen, they may be in shock and should be treated for that. If bleeding is severe, control of that hemorrhage takes precedence over everything else. If the medic finds that the person is unresponsive, unconscious, struggling to breathe, has a very altered pulse, is showing signs of shock, is bleeding severely, etc., emergency services must be contacted. Call 911, continue rendering aid. Patient assessment if they are capable of answering your questions. Sometimes the medic knows the injured person, their family member, a housemate, a friend, a coworker, a volunteer they work with, or even another medic. Other times, they're a complete stranger. Regardless, the primary concern for assessing a conscious and communicating patient are basically the same. First, obtain consent. Yes, even if the person is a member of a medic's family, they still should ask for consent to assist them. Secondly, prevent further injury. Bleeding injuries, even minor ones, can cause the injured person and onlookers to pass out. It is recommended that the bleeding person be placed in a resting position. If there is any doubt as to how the person is coping with their injury, they're dizzy, they're lightheaded, they're white, they're blanking in and out in the middle of sentences, or the bleeding is heavier than a small nick, that position should likely be fully supine, which means laying flat on the back, staring up at the ceiling, staring up at the sky. Bystanders may also need to be directed to sit or lie down if they also show signs of presyncope. Some people pass out if they see bleeding, even if it's not their bleeding. It just happens. The medic should ask about any medications that thin the blood, including but not limited to aspirin, warfarin, rivaroxaban, dabigatran, apiazaban, and clopidogrel. They should also ask the person has a history of excessive bleeding or clotting insufficiency. They should ask if they are on any anticoagulants, as if they are, a minor injury can lead to significant blood loss and shock. They should ask if they are on any medication that affects how the body handles shocks, including beta blockers, calcium channel blockers, antidysrhythmics, and nitroglycerin. Older adults are more likely to be taking medication that makes bleeding injuries more severe. Additionally, their blood vessels may be affected by age-related illnesses and disease, and thus less able to constrict. They are more likely to suffer severe cardiac effects from shock, so just expect that with an older person. A small portion of the population has hemophilia, meaning they lack one or more of the blood's clotting factors. Because their blood just does not clot, all abrasions, avulsions, and lacerations on a person with hemophilia should be assumed to be very serious, and they should be transported into emergency medical services immediately. Pregnant people will naturally have a faster pulse, lower blood pressure, and often nausea, so evaluation of them can be a little complicated. We recommend that their symptoms still be taken seriously if they present with the signs of shock, even if the signs of shock could be caused by them being pregnant, and that medics not automatically dismiss the altered signs of a medical state as being caused by someone being pregnant. The medics should inquire how painful and tender the injury is. They should also check for signs of swelling, as this can indicate a more severe injury. They should always monitor and treat for shock if heavy bleeding is occurring. If someone is bleeding heavily, just assume shock and treat them accordingly. Yes, we are going to get into treating shock. Sterilization of the self. The medic should always sterilize their hands before handling any wound, even if they intend to wear gloves, as the gloves serve more to protect them from bloodborne illnesses than to protect the person that they're assisting from germs. In an environment where it is possible, they should wash their hands, wrists, and forearms with soap and water. They should run clean water over their hands, remove their hands from the flow of water, add soap, scrub their hands, wrists, and forearms for at least 20 seconds per area, then rinse them clean. Ideally, they should air dry, but sterile wipes can be used to remove excess moisture. They should then put on gloves. They can also use a povidone iodine scrub, betadine with a surfactant added, to wash. We're going to get into more on that later. In a field without access to running water, the best solution is povidone iodine wipes. Povidone iodine, also called betadine, is a complex consisting of the antimicrobial agent iodine and the carrier molecule povidone. Povidone iodine is effective against both gram-positive and gram-negative bacteria, fungi, and viruses. It also takes like 30 seconds to wipe yourself down with it. I'm going to warn you, it stains like crazy. It will stain anything you are wearing this really awful color of yellow-brown. There is a reason that my entire medic kit is black. Okay. If there is no other option, the medic can sterilize with sterilizing wipes or hand sanitizer with 60% alcohol or higher, then put on their gloves. If there's no other choice, they can put on gloves without cleansing their hands, but they should be aware that this is likely to contribute to the chances of a wound developing infection. The field itself is not sterile. The wound itself is not sterile. It's gonna have to get cleaned later anyway. Don't let not having gloves be the reason why you don't help someone. Does that make sense? Okay. Wound treatment. The goal of wound treatment is to achieve the best possible outcome with the fewest problems. Best outcome, fewest problems. You are never, or nearly never, for anything more serious than like a small nick from a shaving or a kitchen knife or like a little bit of a skin knee, going to have no problems. The aim is to have as few problems as possible. All bleeding except minor oozing during the wound healing stages should be controlled. That is the first step. Step 1 is to assist with hemostasis. You do gentle, direct, continuous pressure, anywhere from 3 to 10 minutes, depending on how heavy the bleeding is. More severe bleeding may require continued pressure from something like a tourniquet that cannot be relieved until the injury is, repaired by a surgeon. Okay. Step 2 is to reduce pain. Pain relief begins with providing compassionate care and professional treatment. For a physician, this might involve use of injected local anesthesia. For a medic, this may involve the use of lidocaine-based anesthetic spray or herbal pain-relieving tinctures. This requires its own safety class, but we're going to get into it a little bit today. Step 4 may be wound exploration in cases where the wound is caused...
Irrigation.
What?
You skipped irrigation.
Thank you. Step 3 is wound irrigation, during which the wound is cleansed to reduce contamination and the potential for infection. Step 4 may be wound exploration in cases where the wound is caused by foreign materials such as a splinter, broken glass, etc. However, in the case of wounds caused by glass or deep puncture wounds caused by a foreign material, this should be done by a professional. Wounds caused by glass may contain glass that is undetectable to the eyes. Step 5 is closure, where the wound is closed. This may not be necessary if the wound has stopped bleeding and it's not at risk of reopening. Step 7 is the application of ointment or salve to prevent infection and speed healing. Step 8 is what's referred to as dressing or bandaging, or dressing and bandaging, where the wound is covered to protect it while it heals. Step 9 is monitoring, where the wound is monitored for signs of infection and to make sure it's healing. Step 10 is follow-up to ensure that the wound was properly handled and has finished the healing process. There are additional steps for medical professionals specifically, such as tissue excision, although medical professionals should really avoid doing this if they can avoid it because it can lead to permanent and uncontrollable issues, so it should really be reserved for dead tissue that cannot be salvaged, and delayed closure. Additionally, their closure methodology may involve stitches, sutures, and the use of injected or ingested antibiotics to prevent infection. Yes?
I just noticed that we made a somewhat embarrassing error, but so that everyone is aware, we did delete a step 6
Oops.
involving tissue excision, and we did not renumber them.
Oops.
So jumping from 5 to 7 does not mean you missed something, it means we missed something.
It means we didn't number them correctly. Thank you, Yen. Yeah, we took out tissue excision. One, you don't do it as a medic. That is not something that you should be doing. It used to be standard practice if a wound had really jagged or inconsistent edges to trim it, to cut those edges so that it had a nice clean closure site. It turns out that doing that is really, really bad for wounds. You're essentially making new wounds and cutting off where all of those, we just went over the healing process, everything that goes to a wound to heal it. By cutting out that tissue, you just removed all of that. Everything the body did to start healing, you just took it out. The healing process starts right away, as soon as the skin is broken. It used to be assumed it started later. It doesn't. It starts right away. So no, we don't clean up edges anymore. So unless the tissue is dead, like necrotic, it doesn't get trimmed. And additionally, you as a medic, you're not taking a scalpel to someone's wound and cutting out dead tissue. That's not appropriate. All right. Managing expectations. People that medics are assisting may have some preconceptions and misconceptions about the assistance that a medic can provide. There is no legal protection for a medic who operates beyond the training and the scope of action medicine. Medics cannot provide injected anesthesia, in-depth wound exploration for foreign material, tissue excision, stitches or staples, prescription antibiotics, etc. And if a wound requires those things, that person needs to seek a medical professional. Medics may be held liable for someone they assist if they mishandle a wound. Even emergency physicians face malpractice lawsuits for mishandled wounds, generally for retained foreign items like wood or glass and undiagnosed injuries to tendons and nerves. Another issue is that people often believe that wounds can be healed without a scar forming. That's impossible. All wounds leave a scar, even if it's minor or difficult to see with the naked eye. Another common misconception is that wounds are fully healed and the body is entirely back to normal when the bandage comes off. But there is a chance that wounds can reopen after healing. As we've already covered, the healed tissue is still very fragile. Bleeding control and bandaging and dressing wounds. Bleeding control techniques with direct, even pressure will stop most blood loss, with the exception of serious wounds that require urgent intervention from other measures, splints, tourniquets, etc. A dry, sterile gauze sponge, these are generally sold in the sizes of 2x2 or 4x4, but they are sold in sheets that you can cut down to size, should be used to exert pressure prior to dressing and bandaging the wound. That gauze sponge should be disposed of and not used in the dressing and bandage to cover the wound after the cessation of bleeding. There are exceptions to this. If you are treating a severely hemorrhaging wound, whatever dressing you first stuck on there and started doing pressure with, that stays on there. You don't take it off and put a new one on because it has the clotting factors on it. But generally, if someone has a small wound and you've applied pressure with a sponge, that one gets taken away. It's going to be blood soaked, it's going to have wound exudate on it, and a clean dressing is put on during the dressing and bandaging. Okay. Continuous pressure needs to be held for a minimum of 10 minutes. Sometimes sponges are secured in place with an ACE wrap or a self-adhesive wound wrap so that the medic does not have to maintain the pressure themselves. Any of you had blood drawn lately? And they use this thing that wraps around your wound that's like a tiny ACE bandage that sticks to itself. That's a self-adhesive wound wrap. And they're used to keep pressure on a wound if the medic needs to be using their hands for something else. They're a little expensive and they are single-use items, but I find them very handy to have in a kit so that you can keep doing other things. Okay. Dressings cover the wound and control bleeding. A bandage... What?
Proceed.
I see that the people who made slides left in some slides from last time. Okay. Dressings cover the wound and control bleeding. A bandage keeps the dressing in place. Yes, the terms are used fairly interchangeably online in medic spaces and stuff, but they do actually have different meanings. Dressings and bandages are used to control bleeding, cover the wound against friction, prevent it from reopening, limit its motion, and prevent infection by acting as a barrier against microorganisms. Dressings need to be porous enough for wound exudate to drain. Wound exudate is the fluid released from a wound during the healing process, which consists of white blood cells, waste products from the breakdown of damaged cells, growth factors, and more. We want wounds to be able to drain. You ever open up a Band-Aid and there's gross liquid on the Band-Aid? That's wound exudate. That's totally normal. Injuries heal best in a moist environment, which can be created with a dressing or topical application of an ointment or salve. Studies have found that wound desiccating, drying out due to exposure to the environment, can delay epithelial layer formation significantly. Keeping the wound moist has been shown to decrease the number of days it takes a wound to heal and reduce wound pain. Antibiotic ointments can keep the wound moist while it is healing. However, research has not established that an antibiotic ointment or salve is better than a non-antibiotic ointment or salve that keeps the wound moist. Petroleum-based antibacterial ointments, neomycin is probably the one you're most familiar with, like Neosporin, and silver sulfadiazine have been found in studies to encourage epitheliation more effectively compared to povidone iodine-containing ointments. Neosporin is better than Bactrin, just a little bit. They're both good, though. Neosporin is easier to find than silver sulfadiazine, which needs to be applied in a thicker layer. Antibiotic ointments that combine polymyxin, B-sulfate, and bactracin, and triple antibiotic ointments containing zinc salt, polymyxin, and neomycin may also be used. Plain petroleum jelly can also be used, but not if the wound was sealed with biodegradable wound adhesive, as the petroleum will disrupt the adhesive from adhering the tissues together. We are going to get into Dermabond. You cannot combine Dermabond and petroleum jelly. It will just take the Dermabond off. The ointment or salve is applied in thin layers without firm direct contact pressing on the wound itself. Dressing should be neat, uncomplicated, and easy for the person to replace themselves. For this reason, simple adhesive dressing and bandages, like those made by Band-Aid, may be the best suited for a wound. The part of the dressing that is in direct contact with the wound should not be sticky. It can't be adherent. For this reason, plain, fine mesh gauze is not used as a dressing because when the gauze is removed, the healing tissues stick to it and it tears it right back open. I cannot tell you how hard it was to find images for this class that did not have fine mesh gauze being used as the first layer of the dressing right against an open wound. No. That is a no. Don't do that. I don't know where that comes from, that is in all of those pictures. I don't know why it's in so many movies. Think of have you ever had one of those bandage gauze rolls and you can see through it? It's got like lots of holes. That has a purpose. It's used for wound packing or for wrapping around and holding in place the non-adherent dressing. It is not used as the dressing because it will stick. The only time you use it as the dressing is for wound packing when you want it to stick. Okay, moving right along. Gauze sponges are best. They absorb exudate without sticking to the wound, pad the wound to protect it, and reduce the risk of infection. Most minor wounds can be dressed with a 2x4 or 4x4 gauze sponge taped in place after all the bleeding has ceased. If a 4x4 dressing is not large enough, not available, it's the wrong shape, a non-adherent dressing base can be cut to conform to the wound area and then taped in place. Tincture of benzoin can be used to protect the skin from medical tape and also provide better adhesion between the skin and the tape. If you are a person that Band-Aids always come off, like you just can't keep them on, some people have really oily skin and bandages don't like to stick, you might want to invest in some tincture of benzoin. You paint it down where the bandage is going to go, you wait a few seconds, and then you put the bandage on. Don't get it in the wound. However, tincture of benzoin must not be applied or spilled on the wound itself, as this can increase the potential for infection. Once a dressing has been placed, it should not be removed until the wound check, 24 to 48 hours later, because it may disrupt the clotting and the closing of the wound. This is why your parents told you leave the Band-Aid on for a day. This is exactly why they said that. If you take it off, it can rip the wound open. Some wounds do not require a dressing or a bandage at all once the bleeding has ceased. If they're very small and stay closed without one, instead just ointment to keep the wound moist may be preferred. The dressing and bandage should be kept clean and dry. The dressing should be changed 24 to 48 hours after application to clean away residual blood and check the wound for any signs of infection. For more serious wounds that can still be treated without emergency services, the person should wait 24 to 48 hours before showering to allow the wound to start to close. They should shower in between dressing changes and reapply the dressing and bandage after showering. They should not take soaking baths until the wound has fully closed. A basic wound dressing consists of 3 parts: non-adherent dressing, wound tape, ointment, or salve. I'm going to point you to when you were a kid and you got a Band-Aid on. A Band-Aid that you get out of the box has a non-adherent dressing. It's the white square in the middle of the Band-Aid. Then it has a bandage, which is the sticky part that causes the dressing to stick in place. They're made as a combined thing. It's just the dressing and the bandage in one. And then if your parents put Neosporin or petroleum jelly on the wound, then that's the ointment or salve. That is a 3-step dressing, bandage, and ointment. And it's what we use if we have a small cut. You just step it up a level. You just make a bigger one if a Band-Aid is too small. Okay? Complications of improperly applied dressings. Improperly applied dressings can be dangerous to the person being assisted. If they're too tight, they can damage the skin, blood vessels, nerves, tendons, muscles, and even organs. If the dressing and bandage are restricting the pulse or sensation, they may need to be reapplied more loosely. If they are too loose or simply provide inadequate coverage, they may fall off and or fail to provide adequate protection from the environment and invasion by foreign microbes. Any of you ever put a Band-Aid on too tight? You can feel your pulse in your finger and your finger started to turn blue? That's too tight. Assessment and management of abrasions. Abrasions typically are shallow and oozing and are often contaminated with foreign material, dirt, gravel, etc. Because a larger area of skin is disrupted and there is often foreign material present, infection may be more likely. We do not recommend medics attempt to clean an abrasion in the field unless there is no other choice. Instead, they can lightly cover the wound with a sterile dressing, and the wound can be cleaned at the medic tent, at headquarters, etc., or by emergency medical services if the abrasion is serious. Assessment and management of lacerations. How serious a laceration is depends on its depth, its length, and what structures were damaged. If the laceration is shallow and not very long, it may be treated by the steps described so far. If the laceration is very deep, it may damage nerves or muscle fibers, which can be evaluated by making sure the person has a normal pulse, that their motor control is still normal, and that they have full sensory function in the surrounding area. Can they feel their fingers? Is anything tingly? Is anything numb? Can they feel their toes? If they have cut their arm, can they feel all the arm around the wound? Is anything numb? Is anything swelling up really badly? Those are bad signs. If a laceration has exposed any identifiable fat or deep fascia, that person should be referred to professional medical services. If the laceration disrupts an artery, it can be fatal. Yes, we will be getting into that. Assessment and management of avulsions. Avulsions may or may not bleed heavily, depending upon where the avulsion occurred and how many blood vessels there are in that area. Avulsions are more vulnerable to infection due to the larger area of skin that is disrupted. Another danger of an avulsion is that the skin will die, which occurs if it is fully disconnected from the body, folded back, or kinked. Circulation has to be restored to the tissue for it to survive and to be able to be reattached during the wound healing process. In cases of serious avulsion while waiting for emergency medical services, medics should make note of how heavily the avulsion is bleeding, the color of the wound exudate, and the consistency of the wound exudate, and relate that information to emergency medical services. If treating a minor avulsion, gently irrigate where the skin was pulled with sterile water, sterile saline, or sterile wound wash to wash away the dirt, the debris, and other foreign matter. We'll get into more detail on wound washing here in a minute. Then gently fold the skin flap back down onto the open wound until it is aligned as best it can be from where it was torn from. Then hold the skin flap in place with a dry, sterile dressing for 10 minutes as in normal wound care. Never remove the skin flap if it is still attached, regardless of how big the piece is. Small pieces may reattach on their own, and bigger pieces can often be reattached by a surgeon. Yes, degloved skins can sometimes be reattached through procedures like replantation or skin grafts, but the success of reattachment depends on the injury's severity, location, and whether blood vessels are intact. In some cases, the original skin can be successfully reattached if its blood supply is intact, while other times a skin graft from the degloved skin or another part of the body may be used to cover the wound, or they may do like a patchwork thing where they use both. Avulsions are best dressed with a dressing held in place by a pressure bandage rather than just medical tape. A pressure bandage is one that wraps securely around the body part the wound is in, putting more pressure than simply taping the edges down. So if you think, I have a square here of a bandage taped in place, that's a regular dressing and bandage. If I then take gauze and I wrap that around and around the arm so that it's putting pressure on that wound, that is a pressure bandage. You will often need a pressure bandage for an avulsion because otherwise the skin wants to just keep trying to fold back. Okay. Locations of dressings. Head and scalp dressings are complicated by the fact that wounds in this area bleed heavily and can cause significant blood loss. If the laceration is from something like shaving, a pebble bouncing up when weed whacking, etc., it may bleed significantly but not be particularly life-threatening. However, wounds on the head and scalp are often, though not always, caused by blunt trauma from falling. People who fall and sustain a laceration need to be assessed for the signs of syncope and concussion. The laceration may also be associated with serious intracranial injury. People who have hit their heads may not be reliable witnesses to their own injury. A person with a head wound can suffer from memory effects caused by the impact or by confusion caused by head pain from the impact. People cannot often clearly convey how they were injured or the severity of what struck them. If a person has fallen and hit their head, they need to be evaluated by emergency medical professionals who can check for skull fractures. Unfortunately, skull wounds are also very common in people who have been drinking heavily, which can complicate their care. Alcohol is a cutaneous vasodilator, so the wound may bleed even more heavily than head wounds already bleed. An intoxicated person is less likely to be able to clearly answer questions as to the mechanism of their injury, how much they've been drinking, how dehydrated they are, whether they've been bleeding for a while, how bad it hurts, etc. Remember, alcohol lessens pain, so they also probably won't accurately report how much it hurts. Scalp injuries bleed profusely, and it can be really difficult to control. However, the rigid skull directly beneath the wound can sometimes help with direct pressure to get the bleeding to stop. Unfortunately, if there is reason to suspect a skull fracture, direct pressure is contraindicated. If there is a concern that the integrity of the skull is compromised at the site of the laceration, more diffuse pressure on the edges of the wound must be used rather than direct pressure on the laceration, which can push pieces of broken skull into the brain. It is difficult to dress wounds on the scalp as hair can interfere with securing the dressing in place, and the shape of the cranium can make the bandage slide up and down. Some medics may choose to shave a small area of hair, but if a laceration is serious enough to require that, it's likely also serious enough to just require an emergency department visit, and then they can be mad at the doctors for shaving their head instead of mad at you. Although there are no current studies concerning hair removal for wound care, some wound care specialists believe that shaving actually has the potential to increase wound infection rate, as it may cause small dermal wounds around the laceration that can act as a point of entry for microbial invasion. A dressing on a scalp wound may need to be held in place by a bandage wrapped all the way around the head rather than taped in place over the area, and then secured by a bandage clip rather than tape because tape doesn't stick to hair. Uncomplicated, simple, small lacerations on the face and scalp, shaving cuts, minor martial arts injuries, etc., are often just left open. As aforementioned, the head and face have a lot of veins, but on the bright side, what causes them to bleed a lot also makes those areas way more resistant to infection. However, they need regular application of a moist salve or ointment, such as petroleum jelly. Facial wounds often cause significant concern to the wounded person, as they may be concerned about scarring. Take extra care to have a calm demeanor if someone's been injured in their face, especially with a laceration. A major concern for facial injuries is that the blood will pour into their airway. So a person with a bleeding wound pouring into their nose or mouth may need to be gently repositioned so they're not choking or aspirating on their own blood. Never shave an eyebrow to make treating a cut around the forehead easier, as they grow back oddly or they might not grow back at all. If you have to, just kind of smooth the hair away from the wound with petroleum jelly. Lacerations to the ear are a common martial arts and sports related injury. They may also be caused by jewelry being ripped out by accident. I don't know if any of you have ever had an earring get ripped out. It's not a fun time. Unfortunately, they can also be caused by falls, which brings us back to assessment for concussion and other head traumas. If the injury is external, it can be treated with an external dressing. A dressing should never be placed inside the ear canal, though. It has to be on top of the external ear. Sterile gauze sponges can be used for this, although the person will likely struggle to hear through them. The sponge may need to be held in place by a bandage wrapped around the head and clipped into place rather than tape, depending on the person's haircut. Ear lacerations sometimes happen from blows to the ear, which may rupture an eardrum. If hearing is lost or if the person has high-pitched ringing, there's a possible rupture to the eardrum and professional medical assistance is needed. Also expect them to be dizzy and really disoriented if that happened. I didn't have that in here. If the blood is flowing from inside the ear canal, do not attempt to use pressure to stem the bleeding. Blood flowing out of the ear is a sign of a more serious injury, including possibly cerebrospinal fluid that is leaking alongside that blood. Stemming the bleeding may increase pressure inside the skull, which can be deadly. Like, you can cause brain damage, you can kill someone. Never shove a bandage up someone's ear. Instead, place a bulky sterile gauze sponge over the length of the external ear to catch the fluid and get the person emergency medical aid immediately. Wounds to the neck, especially lacerations, can be very dangerous. I want you to think about, every movie you've ever seen someone get their throat slit. It's kind of a big deal to have even a shallow wound in certain areas of the neck. If the wound is very minor and shallow, a shaving wound, for example, it can be treated as a normal laceration. However, even a minor neck laceration from a different cause, such as a car accident where a seatbelt has lacerated the neck, or a person falling against a sharp object, can be extremely serious. There are important large blood vessels in the neck. The airway and the cervical spine are in the neck. A minor neck laceration can also cause an air embolism or disrupt the airway. A small puncture can impact the spinal canal. If a person has sustained a bleeding laceration to the neck that isn't from a very minor, very shallow cut, again, think something like shaving, an emergency services must be contacted. The medic should monitor for signs of severe blood loss and difficulty breathing. Open injuries to the neck should be treated with an occlusive dressing. Occlusive dressings are used for sealing particular types of wounds, including sucking chest wounds, for example. They protect the tissue from air, fluids, and other harmful contaminants and are used as an immediate means of controlling the cleanliness of a wound, as well as the loss of blood until emergency services can be provided. Occlusive dressings in neck injuries prevent air from being drawn into the circulatory system through the wound. The dressing needs to be placed carefully so that it doesn't restrict blood flow to important vascular structures of the neck or prevent air from flowing through the trachea. Basically, don't strangle someone with the dressing and the bandage. Okay. Lacerations to the shoulder are generally fairly easy to dress and bandage using the standard techniques. They may be complicated by the mechanism of injury, however. If the laceration is from an injury that also wrenched, dislocated, or broke the shoulder, that injury will also have to be dealt with. If the injury is being disrupted by movement in the shoulder, a sling may be needed to prevent motion until the wound heals. Shallow lacerations and abrasions to the torso are generally easy to clean, dress, and bandage, but deeper wounds to the torso need to be accompanied by a thorough assessment for any internal trauma. Most dressings on the torso need to be taped in place, as a wrap-style bandage like those used on head injuries can impede breathing. This guide is not on penetrating injuries, so we will note that any injury to the chest should be assessed for pneumothorax or hemothorax. Wounds to the groin should ideally be treated by a medic of the same gender. Special care should be taken to preserve the person's privacy and feeling of control over what is happening to their body. If the person will not permit the medic access to the wound near the genital area, they can be provided with a dressing and directed in the care of it themselves. Groin wounds tend to bleed a lot, especially those to the thin skin of the penis, vulva, and perineum. Shaving cuts, zipper-related injuries, and similar injuries can bleed a great deal. The amount of blood is not always indicative of the seriousness of the injury. If it is a shallow tear or cut, treating it as any other injury, pressor, dressing, watching for infection, etc., is acceptable. For shallow cuts, washing with sterile water, sterile saline, or sterile wound wash is generally enough to prevent infection, but any sign of infection should be addressed with medical attention by a professional. Shallow tears inside the vagina often heal on their own. The person should use a panty liner or a pad for a few days rather than attempt an internal dressing. They should not use tampons, menstrual discs, menstrual cups, or engage in penetrative intercourse until the wound is fully healed. They should not take soaking baths, although showers are acceptable. If, however, there is any kind of exterior avulsion to the genitalia, deep or wide internal lacerations to the vagina, or deeper lacerations to the vascular and muscular structures around the groin, emergency medical services may be required. This guide is not going to address internal lacerations to the anus. We address that in our Mastery of Herbalism and Comprehensive Sex Education courses. It also does not address lacerations that are caused by sexual assault and or rape, though that is covered in a different guide and class in this course series when we talk about dealing with sexual assault and rape. The hands, wrists, and fingers are among the most common injury sites. Any jewelry should be removed from a hand that is injured, even on adjacent fingers that are not injured. If the wrist is injured, any jewelry or watches must also be removed. The finger and hand can swell rapidly after wounding, which can cause jewelry and watches to act as constricting bands. Blood flow to the tissues can then be restricted, which is called ischemia, which can cause severe injury up to amputation. If they have already become stuck in place, they may need to be removed with a lubricating substance, oil, oil-based soap, lubricant. If that's not possible, they may need to be cut off. Jewelry often has sentimental value. Be careful not to misplace any jewelry removed from the person that you are assisting. Unfortunately, sentimental value cannot be factored into the decision of whether or not to cut off a ring. If the person is going to lose their finger, the ring needs to be cut off. Medics cannot force this decision, though, but they may need to make it clearer what the consequences will be if the ring is not capable of being removed by other means and the finger is swelling up. A jeweler can almost always restore a cut ring. Note, titanium jewelry may need to be cut off with specialized tools. Fire departments often carry these tools. Some EMTs carry these tools. Special care has to be taken when dressing wounds to the fingers and wrists not to wrap the bandage or tape circumventually around an extremity or finger. If brought around the finger and the wrist to adhere to itself, tape and bandages can become a non-expanding band. This can cause a tourniquet effect, causing ischemia and again the potential for amputation. The edges can be angled so they do not create a perfect tight circle around the finger, or square taping can be used. This is the mistake almost all medics will make at some point. They will get a finger wound all dressed and bandaged, and then the finger starts to swell because they put the bandage in a perfect circle around the finger. You actually angle it slightly so that one end doesn't line up with the other one, so that blood can still move in and out of that finger. The dressing and the bandage can be just as dangerous as a ring. Okay. Wounds to the wrist need to be assessed for depth. There are veins and arteries in the wrist that, if cut, cause severe bleeding and risk of death. Shallow cuts can be treated like any other, but the assessment must check for how heavily a person is bleeding and the depth of the cut. Hands are complicated to dress because of how often they move, especially with injuries to the palm. I do not know why in every movie they cut across the palm when they want to get blood. That's a terrible idea. Don't do that. Because of the movement of the area, it may be necessary to use a wrap-style bandage to hold the dressing in place rather than tape it on. Deep injuries to the palm are of concern because of the numbers of nerves, tendons, and ligaments in the palm. The assessment should check for numbness, tingling, difficulty opening and closing the palm, difficulty moving any of the fingers. If any of those are occurring, the person will need emergency medical treatment for the injury, possibly including surgery. Remember that they may not necessarily notice right away that a tendon has been cut, so visual inspection is also important. Joints are not difficult to treat for bleeding, as the bone underneath makes pressure easier to apply. However, they can be difficult to dress and bandage after that because of the high tissue stress and all the movement in the area. Elbow injuries need to be checked for neurovascular damage because the ulnar nerve and brachial artery are located very shallowly in that region. The depth of the wound should be assessed, as should the rate of bleeding. The person should be monitored for signs of tingling, numbness, and difficulty moving their forearm, hand, and fingers, particularly the pinky and the ring fingers. Wounds caused to joints by impact may additionally be complicated by injuries to tendons, ligaments, and bones. The person should be addressed for breaks and dislocations. If there's a reason to suspect either, again, contact emergency services. The ankle and the foot are also commonly injured. If the foot is injured due to a crush injury, the severity is extremely important to assess. Something like a falling box can still break bones. I broke my foot dropping like my kid's toy chest on it, and I broke it badly. It was not a fun time. And also, it lacerated the skin when it fell on it, so I had the cut and the crush injury. Blisters can be stripped off the skin, similar to an avulsion, although an avulsion always refers to a violent skinning of skin and possibly underlying tissue, rather than what happens with a blister. A blister is a separate kind of injury. However, they're treated the same way. If possible, the skin is laid back down, not ever torn free. That thing they told us as kids, puncture it with a needle, roll the needle across it, take the empty skin off, that's wrong. That is not at all what you should ever do to treat a blister. You want to leave them alone, and if the skin has peeled back, you want to lay it back down, just like in an avulsion, and dress it like an avulsion. It is then dressed and bandaged in place. For blisters that were caused by friction, not heat, we recommend hydrocolloid dressings. They're called blister band-aids. You can find them at the pharmacy. Wounds to the bottom of the foot are very difficult to keep dressed. The person may need extra padding on the dressing too, because every time you step, it tends to rip the wound open, so you need extra. They may also need to just not walk on that foot until the laceration is healed. Children with abrasions and lacerations. Children get injured really frequently. Lacerations make up approximately 30 to 40% of all injuries treated in pediatric emergency departments in the United States. The annual rate of laceration in the United States is about 50 to 60 per 1,000 children. AMAB children are about twice as likely to suffer lacerations as AFAB people as children, as they are often encouraged to participate in sports and in riskier activities, whereas AFAB children are not. Children may additionally be special needs to be taken to assist children with abrasions and lacerations. Children, hopefully, may not have experienced much pain before, and so it may be an extremely shocking and fearful experience for them. Remember that what's a minor day for you may be the worst day that a child has ever had in their short life. Be compassionate. Children may additionally be a syncope risk, as they are hopefully not used to the shock of injury or the sight of their own blood. If possible, the child should be allowed to sit in the lap of a parent, caregiver, guardian, etc. while being treated. If that is not possible, they should be allowed to hold on to a comfort item. Failing that, care should be taken to comfort them as much as possible and distract them as much as possible from what is happening to them. Medics should talk with a compassionate, gentle tone to all people that they're assisting, but especially children. However, they should refrain from talking down to a child or using baby talk. They should take the time to explain every step of what they are doing and why. Care should be taken to tell them upfront and honestly when something is going to hurt and how much before acting in a way that contributes to the child pain, such as putting pressure on a bleeding wound. Assuming that it is not a life-threatening emergency, the medic should never shift clothing to better access a wound without explaining everything and getting consent from the parent, guardian, or caregiver and from the child themselves. When determining the mechanism of injury, a child 4 and older should be able to answer simple questions about what happened. 4 and under, if a kid is really badly injured, just call EMS and try and comfort and monitor for shock, because they're not going to be able to tell you the mechanism of injury. During assessment, a medic should never make false promises. They must never say that they will only look, they promise not to touch, it isn't going to hurt. Don't lie to kids while you're treating them. It makes them very upset. They don't like being lied to any more than we do. If there is time and the child is not severely bleeding, the medic should take time to work their way up towards an injury. They can be asked, so you sort of like, if the wound's on the finger, start by gently prodding the elbow, then the forearm, and allow the child to get used to being handled by a stranger before there's any touch to the wound. It stops them from jerking back and potentially worsening their own injury. Children may need to be distracted from the direct pressure and then dressing and bandaging of the wound. They can be asked about their siblings, their friends, favorite activities, etc. So long as they don't need to be fully immobile, they can be allowed to color with an uninjured hand, blow a bubble wand, watch a video, listen to music, or play with a sparkle wand. Younger children 3 and under may need a pacifier and blanket. If a parent, guardian, or caregiver is present, they may wish to be the one putting pressure on a child's injury. So long as they keep adequate pressure, this should be encouraged rather than a stranger touching a child. The parent, guardian, or caregiver can also possibly be the one to apply topical anesthetics if they're willing to cleanse their hands appropriately. Lidocaine spray or cream can be used to teeth the child for pain before finishing dressing and bandaging the wound. Parents, guardians, and caregivers may also be very upset at the sight of their child in pain. They may react with anger, suspicion, judgment, or with pre-syncope or syncope themselves. Care should be taken to primarily address the injured child's needs, but also to manage the adults. Sometimes an adult may need to be sent a few feet away to calm down. If this upsets the child, it can always be reversed, but sometimes the child is actually calmer when the adult has walked off and isn't contributing to them being afraid. Young children may not be able to report the symptoms of loss of function due to a tendon, ligament, or nerve damage, so assessment needs to include more questions, such as, can you feel this? Is this tingly? What does, just really leading and asking lots of gentle questions. If possible and the wound isn't too big, Band-Aids are the best dressing for children, especially if colorful and age-appropriately decorated. Keep kid-friendly bandages in your med kit. Have superheroes and princesses and things that sparkle. It makes it a lot easier to have them accept a dressing. Children are more likely to leave a Band-Aid in place than a sterile gauze pad that is taped into place. Parents, guardians, and caregivers can also be given additional Band-Aids to place if the child does remove the Band-Aid to look at their injury. Sometimes children can even be taught how to put on their own Band-Aid, which may help them want to keep it in place because they're the one who put it there. If a square dressing, such as a gauze 4x4, has to be placed, the adult should be walked through the process so they can replicate it on their own if the child removes it. For puncture wounds, wounds caused by rusting materials, or wounds caused outdoors in the dirt, there is a tetanus concern. This is true for adults as well. Parents often don't want to discuss vaccination with medics, and we are not medical professionals who can insist on knowing whether the vaccination schedule has been followed. But we can gently suggest it might be something to bring up in a follow-up visit to a pediatrician or while seeking emergency care if the wound is serious. If the injury is not consistent with the story given to explain it or consistent with the developmental age of the child, the medic should be alert for signs of physical abuse. If the laceration is consistent with a blow from a belt, hanger, rod, etc., or if it's an unusual spot not generally prone to injury, buttocks, back of the thighs, and the back, then social services should be contacted. In the state of North Carolina, where this class on this topic is currently being taught live, all adults are mandatory reporters, and there may be charges associated with failing to report child abuse. Additionally, and more importantly to the staff of Sanctum of the Craft, it's an ethical imperative. Okay. Wound exploration for foreign material. Sometimes wounds need to be expected and explored beyond a basic assessment. This is particularly relevant when an avulsion or laceration appears deep on initial assessment and or passes over areas with many veins, arteries, tendons, or nerves, or if there is foreign matter in the wound. Foreign matter can be dirt, gravel, glass, pieces of metal, plastic, pencil graphite, vegetative debris, thorns, for example, and teeth, but that's more relevant to the guide on treating bites. Foreign material is called a foreign body if it is lodged in the soft tissues. It is classified as inert or non-reactive if it is one that doesn't cause an inflammatory reaction as it breaks down in the body. Inert foreign bodies are sometimes left in place by physicians if they will not cause damage to the person because the body encapsulates them within the soft tissue and heals around this. More on this when we get into bullet wounds. Although glass is inert, large pieces must be removed, although small, insignificant fragments are sometimes left in place. Organic reactive objects are organic materials that break down in the body. These lead to infection. These include soil, gravel, wood, bone, teeth, and rubber. Soil, in particular clay, is of particular concern for causing microbial invasion in a wound. Guess what kind of soil most of North Carolina is? It's clay. If the wound is suspected to have glass, gravel, or metal in it, a radiograph under professional medical care may be needed to determine if all of it has been removed. In the case of a medic performing wound exploration, we cannot do what emergency room medical professionals would do and draw the edges of the wound apart with tissue forceps, retractors, or skin hooks. We can't do that. But we can search for obvious signs of foreign bodies, discoloration under the epidermis, or a visible mass. If direct visualization is difficult, we can use sterilized gloved hands to gently palpate the area to feel for foreign material. Gently probing of a non-anesthetized wound will often reveal foreign matter to the injured person, as they will feel it shift around. If the object is a wooden splinter, it needs to be felt for before it's softened by absorbing fluids, because then you can't feel it. The most common retained foreign material is glass, and people who have glass in their wounds cannot accurately tell whether there is any glass remaining in it. A radiograph under emergency care from a professional is necessary for anything but the very shallowest of glass lacerations. Retention of foreign bodies happens most often on the feet, the hands, and the head. Although this is more relevant to our guide and class on puncture wounds, we will note here that it can be difficult when treating wood splinters in a laceration not to just grab it and yank it out. Even shallow splinters should ideally be cut out, because wood splinters pulled out can leave small fragments behind, as the entry wound is small and friction can strip off tinier splinters. By creating a shallow incision, the splinter can be lifted out in its entirety. The laceration to remove it is then treated like a normal laceration, but with extra thorough debridement and flushing with sterile water, sterile saline, sterile wound wash, etc., before dressing and bandaging. Wounds that contained organic material are not often closed with Steri-strips, zipper closures, biodegradable tissue glue, sutures, or staples after being thoroughly and copiously irrigated with sterile water or sterile saline, because that site needs to fully drain. Not allowing the site to drain can lead to infection and abscess. So, for example, if a surgeon is dealing with a wound that was significantly contaminated and they had to do a lot of wound washing, they will wait for it to start closing in and fully draining and then do closure later. Okay. More on wound cleansing, irrigation and debridement. Getting a wound clean with no foreign matter remaining and keeping it clean as it heals are vital steps to wound management. Several skin and wound cleansing preparations are available commercially to medics. The clinical data on their efficacy has primarily focused on surgical use, but lately more data has come out on skin cleansing in emergencies by medics and EMTs. Povidone iodine is manufactured in solution or combined with an ionic detergent, povidone iodine surgical scrub. The scrub should not be used on an open wound for cleansing, irrigating, or soaking. It will damage the cells. The scrub is designed to scrub the hands of a person about to work on a wound, or to scrub skin that is going to be cut into, such as in the context of surgery. Povidone iodine without the scrubbing detergent is distributed as a 10% solution, and it needs to be diluted to a 1% concentration in sterile saline or sterile water before being used to irrigate or soak a wound. It will retain its antimicrobial abilities, but it's very gentle on the damaged tissue at that dilution. Povidone iodine diluted with sterile saline to a 1% concentration can even be used on the eye with no reported corneal, conjunctival, or skin toxicity. It's often used to wash out eyes after exposure to chemical weaponry, but I prefer just sterile water, personally. Adverse and allergic reactions to povidone iodine dilutions are very, very rare, even when patients have previously reacted to more concentrated iodine. Povidone iodine is available over the counter, and it is our preferred solution to carry in medikits because of its cross applications, its ease of use, and its safety profile. You can use it to sterilize water, you can use it to sterilize your hands, you can use it to sterilize a wound, you can use it to irrigate a wound. It has a lot of applications, so if you're going to carry one thing, carry that thing, and just be prepared for the staining. Chlorhexidine is an antibacterial agent very effective against gram-positive bacteria, but not nearly as effective against gram-negative bacteria. And whether it affects viruses is currently unknown. I couldn't find any studies. Repeated use is contraindicated because it can build up on the skin and affect the natural bacterial balance that should be maintained on your hands. However, for this exact reason, many EMTs actually prefer it because it suppresses bacterial growth on the skin in a prolonged fashion, so it keeps their hands more sterile. It also comes in a scrub version combined with ionic detergent, and that version is also not safe to make contact with an open wound. Chlorhexidine is available as a pre-mixed wound wash over the counter and does not need to be diluted before use as an irrigant or soaking solution. For this reason, again, some medics prefer it because you don't have to dilute it in sterile water. You can just use it as is, like right out of the bottle. Non-ionic surfactants are surface active agents with the cleansing action of soap. But without the potentially damaging effects of some soaps, even on tissues that normally react poorly to surfactants, like the eye. Examples of these include F68, called SureCleanse, and Polaxamer 188, called PharmaCleanse. Polaxamer 188 was trialed on over 3,000 patients with no serious adverse effects. However, they have no antibacterial activity against gram-positive or gram-negative bacteria. For this reason, if a wound is suspected to be contaminated by organic foreign material or at a particular infection risk, povidone iodine will probably be preferred. For shallow wounds or wounds to the face, especially around the eyes, nose, and mouth, non-ionic surfactants may be preferred because we don't want to get it in the eyes. You had a question?
So the povidone iodine, the scrub is what you can use for hands and irrigating?
You cannot use it for irrigating.
Okay.
The scrub is only used to scrub intact skin. So you shouldn't even use it on yourself if you have lots of cuts and stuff on your hands. If you don't have lots of cuts, you can use the scrub to scrub up before you work on someone, but you also don't need the scrub. You can just use povidone iodine solution to wash your hands. So personally, I don't bother buying the scrub. For one thing, my hands are never intact. I garden, I do martial arts, I constantly have like cuts on my knuckles, cuts around my fingernails. It's not a good idea for me. So I only carry povidone iodine 10%. Okay. I don't bother carrying the others. We do not recommend hydrogen peroxide. Hydrogen peroxide bubbles when it comes into contact with blood and tissues, and that foaming was originally believed to work in a debriding fashion, flushing out foreign material and harmful microbes. But it isn't actually an effective germicide, and the bubbles are insufficient to flush out foreign material. Additionally, that bubbling actually separates the healing cells from the damaged tissue, delaying wound healing and leading to a greater risk of infection. If your parents ever poured hydrogen peroxide on your wound to get the gravel out, I'm so sorry. That does not work. That does not take gravel out of a wound. All it does is hurt. The steps of wound irrigation and soaking. Before cleansing and irrigating a wound, the medic should thoroughly wash or cleanse their own hands if possible. As aforementioned, they can do this with soap and water or with povidone iodine. If possible, such as at medic headquarters, we recommend medics wash with povidone iodine scrub or povidone iodine solution or chlorhexidine. If they are concerned about staining their clothing, they should use chlorhexidine. They should wash each part of their hand, wrist, and forearm for 20 seconds per area. Ideally, they should allow their hands to air dry. In the field, it often isn't possible to wash hands in this fashion. Additionally, the field and the wounds are already not sterile. Because wound irrigation is often painful, the medic may wish to spray on a lidocaine spray, use a wound wash that already contains lidocaine, because some of them are pre-mixed with lidocaine, so it's killing the pain in the wound while washing out the wound. They're just more expensive. Or gently apply a lidocaine gel. Unlike medical professionals, we cannot administer injected anesthetics, so if that is necessary, the person should seek emergency medical services. The wound is then cleaned. Periphery wound cleansing involves washing around the outside of a wound to remove visible contamination and dried blood. This is done until the wound is visibly clean on the outside. 10% povidone iodine solution, not the surgical scrub preparation, which again should never be in a wound, diluted 10:1, can also be used as a periphery cleanser as well, or you can use the wipes that are pre-made. Never take a periphery cleansing sponge and move it in from the contaminated exterior skin to on top of or inside the wound. So if you've been cleaning dirt and stuff from around a wound, don't take that same dirty cleansing sponge or wipe and then stick it in the wound. The point is to get the stuff away from a wound, not further contaminate it. Wound irrigation is scrubbing of the wound itself is not recommended. It has not been shown to decrease the rate of infection and can cause further trauma to already damaged tissues. If a wound is visibly contaminated with foreign matter that does not flush clean with irrigation, it's going to require removal by a medical professional. Wound irrigation is the most effective way of reducing foreign matter and the presence of harmful microbes in a wound. High pressure streams are more effective than low pressure streams. A bulb type syringe can only reach a PSI of about 0.5 to 1, and an ideal wound irrigation requires a stream above 5 psi. To increase the pressure of the liquid, it is common to attach a piston syringe full of the liquid into a needle or catheter with a lower opening diameter. A 35 milliliter syringe attached to a 19 gauge needle can reach 7 to 8 psi, and that's ideal for wound irrigation. That level of pressure flushes foreign matter and microbial contamination from lacerations very easily. Emergency medical services may use even higher pressure, up to 70 psi, in pulsative lavage, but they can also fully anesthetize a wound before they do that, which we cannot. This may be required for larger, heavily contaminated wounds that are being treated by surgeons. That is being done while someone is unconscious, or there's nerve blocks, or they are fully anesthetized. We recommend the use of sterile saline, sterile water, or wound wash, but intriguingly, a recent study performed on 530 pediatric patients, so kids, compared the use of saline irrigation to running tap water and found no difference in the level of wound infection afterwards. However, this study was performed on very small lacerations that had very low levels of contamination with foreign matter. While irrigating a wound, the person should be seated or ideally laying down. They will react to the flushing of the wound with pre-syncope or syncope like a lot. It hurts. It's not a fun thing to have done. The wound should be irrigated with the syringe held very closely to the wound so there is limited splashback on the medic and so that the force is being more directly applied. It generally takes about 100 to 250 milliliters of fluid to flush a wound fully. However, this can vary a lot depending on the level of contamination. Again, if the wound is very large or very badly contaminated, this should wait and be seen to by a professional or by emergency medical services. Cleansing is complete when the wound looks clean, pink, and there is no visible contamination or foreign bodies. Sometimes there is fresh bleeding that needs to be stopped using direct pressure before the wound can be dressed and bandaged. Wound soaking is also sometimes used for abrasions or small shallow avulsions, but it's not effective for lacerations because soaking solutions cannot penetrate beyond 1.5 millimeters of tissue even after 20 minutes of wound soaking. In studies on using povidone iodine solution as a wound soak for lacerations, the bacteria counts were lowered, but significant contamination remained. You want to flush, not soak. However, if there's a lot of dried, stuck-on blood and contamination on the periphery of a wound, soaking prior to mechanical periphery cleansing and irrigation may be recommended, as it can loosen the dried, stuck-on matter so that the wound cleansing is less painful and it takes less time. The timing. The chance of oh, yes.
So in the field, are you just using like bottled water?
You're using sterile water, which you can purchase.
Oh.
It's not super expensive to get sterile water or sterile saline, and also a lot of the time you can get it donated. Like I have bottles of wound wash that were donated to me. If you don't have a choice in the field, you can just use bottled water. You can just use tap water, especially if it's not a severe wound. But if you have the option, especially in a medic tent, go ahead and use something like a povidone iodine solution. Now, keep in mind, adding povidone iodine to water sterilizes the water, so you don't have to use povidone iodine and sterile water, because it's going to sterilize it. Anyway, now it takes 30 minutes to fully sterilize water with povidone iodine.
I don't remember. I have to look at
That's for drinking it, though, if it's been contaminated.
How much would you need to use for how much more?
the ratio.
You want to dilute the povidone iodine to 1% of
So 9 parts water to 1 part, 10% povidone iodine solution.
for a wound wash. The ratio for sterilizing water is much smaller, and they actually just sell tablets, and the tablets will have instruction on how many tablets you add for how much water. Okay.
What that means is that if you dilute it to the right concentration for wound wash, you have more than enough to sterilize it.
Use a lot less for drinking water. The chance of developing an infection increases with every hour that passes from the time of injury. How long a wound is safe to be left untreated varies significantly by location, depth, mechanism of injury, and level of contamination. The average simple laceration should be addressed within 6 to 8 hours to prevent complications from delayed treatment. However, most injuries, if treated less than 24 hours from the time of injury, can be converted. This is where you return it to a fresh-ish state by thoroughly following the wound cleansing steps with wound washing. They can then be treated with pressure, application of ointment or salve, dressing and bandaging, just like a fresh laceration. This is something I've had to do a lot with unhoused people when I'm helping the unhoused, because their wounds are often not fresh when I'm washing them. They're often 24 to 48 hours old. And so you convert it to a fresh-ish wound by washing it. Okay. Some wounds that are 3 to 5 days old can still be converted to fresh-ish wounds by medical professionals, but they will probably use surgical excision of dying tissue in that particular case. So we can't do that. Deeper and or longer lacerations. Sometimes a laceration is deeper and or longer than can be adequately treated with just a dressing. In this case, if the wound is so deep as to require sutures or staples, then it is possible that Steri-strips, zipper wound closures, or biodegradable wound adhesive can be used. A wound may not be able to be closed with Steri-strips, zipper wound closures, or biodegradable wound adhesive if it is very deep or very wide. If the wound meets the following criteria, that it should not be closed by these closure methods by a medic. A surgeon might still use those methods. They're really common now, but we should not be the ones doing it. More than 1/4 of an inch deep, more than 1 inch long, if there's visible fat, muscle, or bone, if it is caused by a crushing injury, if it opens so wide that it cannot be closed together with light pressure, if it has jagged edges, or if it is significantly contaminated, especially by glass or metal. I'm going to note here that I have absolutely closed bigger wounds than this for people, but it has been for people who would not go seek medical help. They absolutely refused. They had their own reasons for doing so. I have never tried to close a wound where I could see muscle. That's not... I have contacted people I knew who would help. Does that make sense? And unfortunately, I don't have those contacts here. Okay. Steri-strips, also called butterfly stitches or butterfly bandages, may be thin in the middle and have two wide, sticky areas on each end, like the wings of a butterfly, or they may be straight, thin strips. They help seal the edges of a laceration together without making direct contact with the laceration. There are many brands other than Steri-strips, including Sure Strip, Cover Strip, Suture Strip, Clear-On, Nishi Strips, and Curi Strip, all with differing porosity, adhesion, flexibility, and strength. Steri-strips consistently rank the highest or very high on tests for best overall performance. That's what I use because they consistently get judged the best by medical professionals. They are sometimes a better option than sutures as they don't need to be sewn into the skin and can easily be removed when the wound heals. They are best used for cuts with straight, clean edges that are 1/2 inch of length or shorter when the skin doesn't move a lot. Steri-strips have shown less infection risk than sutures. They are also sometimes better than sutures for elderly or steroid-dependent people with fragile skin because sutures can just tear out. Steri-strips do not work well on surfaces that are oily or hairy, on joints, or on very loose skin. If the medic is not buying pre-cut Steri-strips or similar, but rather a length of Steri-strip tape, the section should be cut with sterile scissors so that there are 3 centimeters of overhang on either side of the laceration. After the laceration is cleansed, it needs to be padded dry with a sterile material. Tincture of benzoin should be applied to the surrounding skin to increase adhesion of the strips, which with care taken not to spill the tincture of benzoin into the laceration. It is then left to dry until it is tacky, which only takes a few seconds. The medic then pushes the edges of the wounds gently together so they are touching but not overlapping and not pinched together. 1/2 of the Steri-strip gets placed on one side of the wound and the other half gets placed on the other side of the wound. They should be placed perpendicular to the cut, not parallel. The next Steri-strip should be placed approximately 1/8 of an inch away from the first one, and so on. A strip of medical tape should then be placed on either side of the wound, and the other half gets placed on the other side. These should be placed perpendicular to... That should say parallel, not perpendicular.
It does say parallel.
Okay. Parallel to the wound. Okay. Along the edges of each of the Steri-strips to help hold down the sticky edges of each of the strips. The laceration can then be dressed and bandaged on top of the Steri-strips if necessary, with care taken to keep petroleum-based ointments away. You do not want them on the sticky part of the Steri-strips. If you use it, it has to be directly on the laceration in the center part, not on the sticky part. And it's really hard to done. You have to use a sterile cotton swab to do it. It isn't always or even frequently necessary to put a dressing or a bandage on top of Steri-strips. The Steri-strips need to be kept dry for 48 hours, ideally longer. They should not be soaked in a bath, but the person can shower after 48 hours have passed, although if they are concerned about the Steri-strips coming off, they can temporarily put a waterproof dressing over them. If a Steri-strip comes off, it can be replaced. Non-adherent waterproof over the Steri-strips. Nothing sticky on the Steri-strip because it can just tear it off, right? So if you have, say you have Steri-strips, put a waterproof non-adherent bandage and then make sure the tape holding it on doesn't pass over on top of the Steri-strips, because when you take that waterproof dressing off, it'll just take the Steri-strip with it. Okay. The person should be instructed not to pull on the Steri-strips as this can rip the laceration open. The Steri-strips may come off on their own as the wound heals over the next few weeks, or they can be removed with a solution of equal parts water and over-the-counter strength hydrogen peroxide. They need to be gently peeled away, not ripped off, as this can open a healed laceration. Okay, go to the next slide. These are all wrong, and this is a fraction of the images I found online that were wrong. Okay, this in particular is not going to allow that wound to drain. They are stacked right on top of each other. You space them apart. You are not supposed to crisscross them like this. I don't understand. These are Steri-strips put over an abrasion, which you don't use them for. You use them for lacerations. All of this is wrong. Some of these were from guides on how to do it. So, okay, moving on. Zipper wound closures are applied very similarly, except that rather than holding the edges of the wound together and then placing the wound closure device, the device is put in place and then ratcheted like a zip tie, which draws the edges of the wound together. Some come with a release mechanism so that the tightness can be loosened if the edges of the wound are drawn too closely together. They are available in short strips and also long strips that are cut to size. The advantage to zipper wound closures is that they do not require the medic or the injured person to keep the wound edges aligned while placing the strips. The disadvantage would be that they might be tightened too much and not have a release mechanism for that tension. Go slowly when pulling the strips to draw the wound's edges together, and stop when the edges are touching but not pinched and not overlapping with each other. Zipper wound closures are stronger than sutures, so they're actually becoming very, very common for surgeons to use in place of them. One of the best wound closure alternatives to sutures is biodegradable wound adhesive. Our favorite is called Dermabond. Before 1998, N-butyl cyanoacrylate, also called histoacryl blue or Indermil, was the most commonly used, but it wasn't very flexible, which meant that it wasn't very effective. Dermabond is sold over the counter in sterile packages and can be stored at room temperature. There are no limits to laceration length that it can be used on. However, longer lacerations should still be treated by a qualified medical professional. Dermabond can be used on both straight lacerations and curved ones, or ones with weird angles and weird corners, which can be difficult or impossible to use Steri-strips or zipper wound closures on. It cannot be used on very wide wounds, abrasions, or avulsions because you don't want to get it into the wound, so don't use it where there's no skin. The healing results of Dermabond closed wounds and sutured wounds are essentially identical. In one study, investigators who followed wounds for 3 months could not tell the difference between lacerations healed with Dermabonds and sutures. Dermabond can also be applied without anesthetic, while sutures cannot. In the first 7 days after application, Dermabond is not as strong as sutures and the wound may reopen. After 7 days, however, there is no difference in the strength of the wound closure between Dermabond and sutures. Dermabond is less effective for children because they tend to pick at the glue and damage the healing process. Dermabond must not be applied to the inner tissues as it is damaging to subcutaneous tissue. Proper application restricts the application of the liquid to just the surface of the skin. It should be used very carefully around the eye, nose, and mouth with care taken not to allow it to drip. Dermabond must not be used on mucous membranes. If Dermabond gets into tissues beneath a laceration, it can cause inflammations, cells to group together inappropriately, misfolding of proteins, and fluid accumulation under the skin. Dermabond comes in a sterile plastic-covered glass vial with an applicator. Because there was originally an issue with Dermabond running into the wound, new formulations are more viscous, and the applicator tip was changed from rounded to chisel-shaped, so you almost use it like a marker. It is also not effective on the bottom of the feet as it tends to tear open when tissues bear weight. After wound cleansing and bleeding is controlled, Dermabond can be used. It does not stick to still bleeding wounds. A rim of petroleum jelly is placed around the edges of the wound about 15 millimeters away from the edges of the laceration to prevent runoff of the Dermabond into other tissues. The person should be arranged so their wound is facing up towards the ceiling or the sky. The applicator is then squeezed until the adhesive covers the applicator tip. The wound is then pressed closed so that the edges touch but do not overlap. The adhesive is then painted over the wound to about 5 to 10 millimeters past its edge. The wound is held closed with fingers while the Dermabond sets. After 15 to 20 seconds, another layer of the adhesive should be applied. That layer then sits for 15 to 20 seconds, and then another layer is applied. After Dermabond is applied, the wound needs to be held together for 60 seconds to 2.5 minutes. Just go ahead and do 2.5 minutes to ensure the edges are sealed together. If they are released too soon, the wound opens and there's a risk that Dermabond will get into the wound. If runoff does happen, it can be wiped up with petroleum jelly followed by acetone. After the Dermabond application, the person needs to keep the wound clean and dry for at least 24 hours. After that period, they can wash in a shower with very gentle pressure. If the wound opens, they need to seek medical care. Unlike sutures, Steri-strips, or zipper wound closures, Dermabond does not need to be removed. It just peels off on its own. The medic and person should avoid using liquid or cream medications on the wound after application, as it makes the glue weaker and results to it coming apart. For this reason, it's important to make sure the wound is thoroughly cleansed before applying Dermabond, since the medic or injured person cannot apply antibacterial cream afterwards. Medics cannot provide suturing or wound stapling. We can't. These are our only methods for things that aren't handled with just a dressing and a bandage. Whew, more severe bleeding. I've got half an hour, y'all. Let's see if I can get through it. If there is severe bleeding from an abrasion, avulsion, or laceration, the medic needs to contact emergency medical services and render aid while waiting for them to arrive. They should be particularly concerned about the trauma triad of death. The trauma triad of death is what it is called. That is not me being like, oh, it's the trauma triad of doom. No, that is literally its name in medical context. It is the simultaneous presence of coagulopathy, I can talk, which is impaired blood clotting, hypothermia, which is low body temperature, and acidosis, the body fluid becoming too acidic in a patient with severe trauma. These three conditions worsen each other in a vicious cycle. The three in combination cause increased bleeding, shock, and ultimately a high risk of death. The medic may need to perform damage control resuscitation to reverse these effects and prevent a downward spiral. Note, some medical professionals are proposing a shift to a pentad model that includes a natural pattern of events occurring with hypoxemia, low levels of oxygen in the blood, as the main trigger for the development of hypokalemia, low calcium levels in the blood, and then hyperglycemia, high blood sugar, and then acidosis and hypothermia, as they feel the original triad fails to establish a sequence which may be relevant during initial treatment of severe bleeding. But most medics have not shifted to this model yet, and I haven't yet, so I'm still sticking with the trauma triad. Even mild hypothermia can inhibit clotting and cause coagulopathy. Coagulopathy tends to increase hypoperfusion, reduce blood flow, which causes the cells to have to use anaerobic metabolism as they aren't receiving enough oxygen. This causes acidic compounds to be released into the blood, which reduces myocardial performance. That then further reduces oxygen delivery even more, which further reduces the body's metabolism, and this leads to increased hypothermia, and it just goes in a circle. Trauma patients have to be kept warm, even if it isn't cold out, even if it's hot out. Heavy bleeding reduces the body's ability to maintain its correct temperature. This is one of many reasons medics should carry shock blankets. They're really tiny, they fold down to nothing, and they're handy for other things too. Having a shock blanket isn't just like a silly thing that they do in movies. Oh, the person's in shock, put on a blanket. It's life-saving. It prevents that trauma triad of death in a lot of cases from ever starting or from it getting worse. Okay. Hypovolemic shock. Hypovolemic shock is a dangerous condition in which a person's heart can't get their body the blood and thus oxygen it needs to function. This happens when a person has lost a large amount, more than 20% of their blood volume, which can happen when they are hemorrhaging heavily. It can also occur when a person is severely dehydrated from sweating or from losing a large amount of fluids from a lot of diarrhea and or vomiting. We just covered hypovolemic shock caused by dehydration in our previous class on sun and heat-related injury. We're now going to talk about hypovolemic shock caused by blood loss, which is hypovolemic shock as hemorrhagic shock, bleeding-related shock. Hypovolemic shock is the second most common type of shock in adults and the most common type of shock in children. Symptoms include changes in blood pressure. At first, the diastolic, the bottom or the second number, increases, but as the person keeps losing fluid, including blood, their systolic blood pressure, the top or the first number, also decreases. Hypovolemic shock reduces blood and thus oxygen getting to organs, which leads to organ failure. The body will prioritize getting blood to the brain and to the heart, which causes the rest of the body, the extremities and the organs, to be hit with oxygen loss first. Hypovolemic shock has 4 stages. In stage 1, a person has lost 15% of their blood volume. If dehydration is the cause of hypovolemic shock, the person will be showing other signs of dehydration, but their blood pressure and heart rate may still be normal. They will feel shaky and unwell. Stage 2, a person has lost 15 to 30% of their blood volume, their heart rate will go up, their bleeding will be very fast, their extremities may feel cool to the touch, and they may be a little anxious at this point. Stage 3, a person has lost 30 to 40% of their blood volume, their blood pressure will drop very low, their heart rate will be very fast, and their breathing will be very fast. Their extremities will feel cool to the touch, they will not be able to produce much urine, they're probably not thinking about peeing, but they probably can't. They may be confused and weak, and they may be struggling to retain consciousness. At stage 4, a person has lost 40% or more of their blood volume. Their blood pressure will be very low, their heart rate will be very high, their breathing will be very fast and very erratic, and most of their body will feel cold, not just cool, cold to the touch. They will not be able to produce urine, and they're probably going to pass out. Other symptoms include extreme thirst, pale or bluish skin, clammy skin, nausea and vomiting, muscle cramps, and extreme fatigue. The average human AMAB person has about 70 milliliters of blood per kilogram of body weight. The average adult AFAB person has about 60 milliliters of blood per kilogram of body weight. The American College of Surgeons Advanced Trauma Life Support Hemorrhagic Shock Classification, which I just ran you through, links the amount of blood loss to a 70 kilogram patient, so someone who weighs about 154 pounds. In the United States, the average AMAB person weighs approximately 90 kilograms, or 199 pounds, and the average adult AFAB person weighs approximately 77.5 kilograms, or 171 pounds. It's just not based in reality anymore, and they refuse to update it to the average size of a person. So the average AMAB person has about 6.3 liters of blood in their entire body, and the average AFAB person has just over 5 liters of blood in their entire body. This changes the math on how much blood can be lost before a person has entered hypovolemic hemorrhagic shock. A quick scan for body weight can be useful. The less a person weighs, the smaller their body, the less blood they can lose before they're entering hemorrhagic shock. Because infants and children have less blood than adults, they experience hypovolemia very rapidly. A 1-year-old child has approximately 2 pints of blood in their entire body, 950 milliliters. So they may suffer from hypovolemia after a loss of only 3 to 6 ounces of blood, so 100 to 200 milliliters. Keep in mind that an average glass of water in the United States is 8 to 10 fluid ounces to help put that in perspective for you, how little blood a child can lose. The most important treatment for hypovolemic shock is to treat the core issue. So for example, if blood loss is the cause of hypovolemic shock, the blood loss must be halted and the person may need a blood transfusion. Hypovolemic shock should be treated by medical professionals such as EMTs or doctors. At stage 4, even if a person receives treatment from a medical professional, hypovolemic shock can be fatal. It needs to be treated as quickly as possible and by the right people. When hypovolemic shock is caused by blood loss, it is referred to as hemorrhagic shock. Hemorrhagic shock is most likely to occur with severe lacerations that damage vascular tissues, amputations, penetrating injuries, blunt injuries to organs, especially if it bursts the organ, long bone or pelvic fractures, and multisystem injury. Hemorrhagic shock can occur from both external and internal bleeding. A factor in how hemorrhagic shock affects the body is how fast it's happening. A person can donate 1 pint over 20 minutes and not necessarily feel adverse effects from doing so. But if the same amount of fluid loss happened over a single minute or even 2 minutes, they may experience hemorrhagic shock. It's how fast the body can compensate for the loss that matters. If an average American AMAB adult person has lost just under 1 liter of blood, they're likely in hemorrhagic shock. This is the equivalent of 2 large beers poured out on the ground. For an average American AFAB adult person, the number is lower at approximately 750 milliliters. This is the equivalent of 1 bottle of wine poured out on the ground. It can be very hard to accurately assess blood loss for visual inspection. In one study, 92 EMS providers had an accuracy rate of only about 8% when estimating a volume of blood at a simulated accident scene, with accuracy defined as within 20% of the actual volume. They could only estimate to within 50% of accuracy about a quarter of the time. 87% underestimated the quantity of blood. Generally, small volumes of blood were overestimated and large volumes were underestimated. So assume if there's a large volume of blood, you're probably underestimating how much there is. A lacerated artery is very likely to cause hemorrhagic shock. As aforementioned, typically bleeding from an open artery is bright red and spurts in time with the pulse. As the amount of fluid circulating in a person diminishes, their hypovolemic shock worsens and the spurting slows to a flow and then to a trickle. Hemorrhagic shock can also be caused by lacerated veins. Venous blood tends to be much darker than arterial blood and slower, which makes it easier to manage, but it can still be serious. What matters is total volume loss over how short of a time, not whether it came from an artery or a vein. Keep in mind that in reality, a wound is very rarely only to an artery or only to a vein, so the color determination may not be helpful. Spurting in time with the pulse, however, that's an artery. We covered the clotting process already, but multiple things can interfere with it, including medication or simply severe damage that's so extensive that a clot cannot completely cover the opening in the structure. Sometimes only part of a blood vessel structure is cut, but it's cut in such a way that it's preventing it from constricting. It should be noted that the symptoms of shock are not a perfect guide to assessing blood loss severity or determining treatment. Symptoms vary and no system of assessment is perfect. The Advanced Trauma Life Support Classification, which was developed by the American College of Surgeons Committee on Trauma, is used by most pre-hospital care emergency services, medics, EMTs, etc. And that describes those 4 stages of hemorrhage and the associated shock that we covered. Unfortunately, there is an absence of clinical research and evidence that the amounts of fluid loss associated with each of the categories actually match the symptoms of those categories. For this case, some pre-hospital caregivers, including medics and EMTs, use a 3-part classification system. It uses compensated shock, decompensated shock, and irreversible shock as its categories. Compensated shock is the stage of shock which the body is still compensating for its own fluid loss, and it's maintaining adequate blood pressure. The body is fighting the fluid loss through vasoconstriction, decreasing blood flow to the extremities and skin. Blood pressure often increases, the person is pale or gray with clammy skin, experiencing nausea because of the decrease in blood in the gastrointestinal system, and they're probably really thirsty. A person's blood pressure may be the last measurable factor to change as shock transitions from one type to the other. The body has automatic mechanisms that compensate for blood loss. These maintain blood pressure, so the blood pressure has dropped, the shock is well developed. Infants and children can maintain their blood pressure until they have lost nearly half of their total blood volume, so blood pressure is not a good way to tell if a kid is bleeding to death. Decompensated shock happens when the person's body is unable to compensate for fluid loss and cannot maintain the brain and vital organs. This occurs if fluid loss is more than 30% of the body's volume. Their blood pressure decreases, their body is cold, their pallor is bluish, their heart struggles, they may have a weak or absent pulse in their extremities, and they're confused and disoriented. They may be struggling to remain conscious. If their blood pressure is very low and they have lost consciousness, they may be heading towards irreversible shock. The term irreversible shock may be irresponsible. It's why I don't like this system and I'm still using the 4-part. It is used to describe a dangerous state of shock when the person is no longer responding to medical interventions, including fluid resuscitation by intravenous IV fluids, blood transfusions, or vasopressor medications, which boost blood pressure by constricting the blood vessels. We say it may be irresponsible because it can make someone think that there's no point in rendering care. If there are signs of life, emergency medical services should keep trying to resuscitate aggressively, rather than just assume the shock is irreversible and the person's gonna die. The goal of the classification system isn't to make people say, oh, this person is in irreversible shock, they can't be helped, but rather to help pre-hospital caregivers understand what is happening to someone they're assisting, determine who is at the greatest and most urgent risk of death, and help them as soon as possible, prioritize them if there's more than one person who is injured. If a person is showing signs of any of these stages of shock, a medic should treat them for it. They should hold pressure on bleeding wounds while waiting for emergency medical services to arrive, possibly assisted by pressure bandaging and splints, tourniquets, etc. If trained and the person stops breathing, they can administer CPR. As we cannot provide IV fluids, blood transfusions, or vasopressor medications, we are not the people who get to determine if someone's in irreversible shock. Medics should never assume someone is in irreversible shock and give up on treating them. Treat them until someone arrives to take them from you or until they are dead. Okay? Everyone clear? Okay. Compensated shock, anxiety, sense of impending doom, agitation, restlessness, weak or thready pulse, rapid pulse, cool clammy skin, white or gray pallor, particularly with bluish or purple lips, shortness of breath, nausea, vomiting, thirst, normal blood pressure. Decompensated shock, confusion, altered consciousness, possibly nonverbal, possibly unresponsive, labored breathing, thready or absent pulse in extremities, ashen, molted, or bluid or show purple skin all over, not just on the lips, low blood pressure. It used to be taught that a person's shock status could be verified by a pulse reading at the radial pulse in their wrist. Any of you ever taken medic classes and they told you could verify someone was in shock from the pulse in their wrist? You can't do that. It's a myth. If there was a radial pulse, the blood pressure could be assumed to be 80 to 99 mmHg, which is adequate to prevent decompensated shock. Recent studies have found that people can still have a radial pulse with a systolic blood pressure of less than 60, so it's just not a reliable indicator. You'll just assume someone's not in decompensated shock and not respond accordingly. The pulse is not what's going to inform you. You need a blood pressure cuff. They're like $20. Stick one in your kit. Okay. Management of hemorrhagic shock. I have 15 minutes. I am not sure I'm getting through these last 10 pages. I am working on it. The first steps of treating hemorrhagic shock are the same as in proceeding to treat any injury. It has to start with scene assessment and ensuring the safety of the medic and bystanders. Standard precautions for bloodborne illness should still be met if at all possible. If the person is conscious, continue with patient assessment in a calm, compassionate fashion. If they are unconscious, check airway constriction and breathing. Heavy bleeding has to be stopped before attempting CPR. You can't actually stop CPR once you've started until they are breathing normally or EMS takes it over for you. So you can't start CPR, then address the bleeding, and then go back to CPR. It doesn't work. Now, someone can be providing CPR while you're putting on the tourniquet. You can split that up and have two of you working on someone. And if their bleeding continues heavily until they bleed out, CPR isn't going to help them. You have to have blood for CPR to work. So blood loss first if it's severe, air loss first if the bleeding is not severe. Everyone clear? Okay. If the person is conscious, help them get into a supine position, remember, laying down. Do not allow the person to eat or drink anything, even if they are very, very thirsty. If they are in hemorrhagic shock, there is no blood in their gastrointestinal system. They are going to throw up. You do not want to be trying to treat someone for bleeding while they're vomiting. It's not a fun time. I can tell you that from experience. The person should be kept warm with a shock blanket while waiting for emergency services. Most external hemorrhage can be halted with direct, even pressure for 10 minutes. Once hemorrhaging is controlled and a sterile dressing or appropriate other bandage has been applied, they can be transported to the emergency department by the emergency services. If a person's bleeding cannot be stopped with firm direct pressure, it may be time to employ more extreme measures. Which brings me to tourniquets. For years, tourniquets were thought of as either a never or an almost never. Even the American Red Cross First Aid and Safety Handbook from 1992, which I do own, contained the information that one should never use a tourniquet. It was in all caps. The common belief was and is that while a tourniquet could stop bleeding, it would result in the limb needing to be amputated. This misconception comes from when tourniquets were used to treat battlefield wounds in World War I, when transport to receive care took a long time to get people off the battlefield. A long period with such reduced circulation often leads to amputation, though not always. With rapid transport, this isn't a concern. Even on the battlefield, medical transport is fast enough that tourniquets are widely used, and the military now issues tourniquets to all field personnel and has done since 2005. Not just medics, everybody gets one. If you're in the field, if you're in the battlefield, you get a tourniquet, everybody gets a tourniquet. There is now a large body of evidence that tourniquets are effective, safe, with a relatively low level of complication rate, and that they save lives. In 2018, a research study by Teixeira and Brown found that civilian pre-hospital use of tourniquets increased survival rates. This is not medics using it. This is civilians using them. This is just an average person using a tourniquet when someone's bleeding to death. There is no increased likelihood of amputation as a result of tourniquet application, not if someone's being treated rapidly. Sanctum of the Craft has been scolded by other medic collectives for teaching tourniquet use. We've been told 4 things primarily. They cause amputations. They don't if they're taken off on time. They can be applied inappropriately when wounds aren't life-threatening enough to require them. They can be applied incorrectly and be ineffective, and they can be applied incorrectly and cause harm. Our answer to the second, that they can be applied inappropriately when wounds aren't life-threatening or enough to require them, is that it is better to err on the side of caution if someone is severely bleeding and you can't get it to stop with pressure. The tourniquet won't harm them if they're transported by emergency service to an emergency department in a prompt manner, and bleeding to death would harm them. Our answer to the third, that they can be applied incorrectly and be ineffective, is to say that the same is true for anything that you're using as a medic, from a dressing to a bandage, and medics should be appropriately trained. But even a not quite tight enough tourniquet is likely to be more effective than simply pressing on a spurting artery with a gauze pad. Without proper placement, the person may die, but without also means no tourniquet, not just a badly placed one. Our answer to the fourth, that they can be applied incorrectly and do harm, is again to recommend better training. The question becomes, what causes the most harm? A laceration of a large artery can cause a person to exsanguinate in as little as 2 minutes. To prevent this, a medic needs to be able to apply a tourniquet in less than 20 seconds. If they are debating with themselves about whether or not they think it's necessary, or whether they will inadequately place it, they may not get it on in time. In that case, what causes the most harm is that doubt. It's that inaction. The medic should get the device in place and then check for blood flow. It is true that an improperly placed tourniquet is dangerous. If the tourniquet is only blocking venous flow and not arterial blood flow, the bleeding can actually increase. They should make sure all spurting blood has stopped and the person is not progressing in the stages of hemorrhagic shock. It shouldn't be getting worse. Tourniquets are only ever applied to extremities and never to the neck, torso, or groin. Whew. Kinds of tourniquets. There are multiple styles of tourniquets available for purchase over the counter that medics can be trained in. They should only carry the styles that they are taught to use, but you should also learn to use as many kinds as you can. The Mechanical Advantage Tourniquet, the MAT, uses a strap and buckle system with a dial to tighten and tension the constricting strap. The Special Operations Forces Tactical Tourniquet, Soft T, which we brought today, uses a strap and buckle system and a windlass, a rod or stick that is used to tighten the tourniquet around a limb, creating pressure to stop or slow the blood flow from a wound that locks into place once the strap is tightened. The Combat Application Tourniquet, the CAT, uses a strap and buckle system and a windlass to tighten the strap to control bleeding, and it also clips into place once the strap is tightened. The Ratcheting Medical Tourniquet uses a ratchet device to apply mechanical pressure. You just kind of keep ratcheting it tighter like a zip tie. The Stretch Wrap and Tuck Tourniquet, the SWAT T, is a combination of pressure dressing, wrap, and tourniquet. They are my least favorite, and they are the most complicated to learn to use correctly, but they also have a lot more applications. Okay. The tourniquet should ideally be placed on bare skin, but medics may not always have the time to remove clothing to place it. If they have time, they should cut, tear, or pull off the clothing that is in the way of their placement. The medic should not remove any dressings that have been used to apply pressure to the wound, as this will disrupt the clotting process. They should stay in place, and the tourniquet should be used in addition to them, not in place of them. The tourniquet should be placed 2 to 3 inches above the injury, between the heart and the injury. Do not place a tourniquet on a joint. Do not place a tourniquet on the injury itself. If the tourniquet is placed on the proximal leg, just below the knee, or the proximal forearm, just below the elbow, there are important nerves that are in those areas that might be at risk of damage if possible. So if possible, go slightly below. You might not be able to. You don't pick where the wound is. But if you can, don't be like right below the knee or right below the elbow. The tourniquet should be tightened until bleeding stops and then no further. It does not need to be tensioned past the point where the bleeding has halted, and doing so can damage the limb. The tourniquet should be tightened according to the manufacturer's instructions and depending on the style of tourniquet being used. If the medic has tightened the first tourniquet as much as possible and the bleeding hasn't stopped, they can use a second tourniquet. It should be applied above the first, closer to the heart. There is more likely to be required for people who weigh more, who have particularly large and muscular thighs. Tourniquets hurt. It is likely that the person being helped will complain of pain. Unfortunately, if they are required to save a life, that pain is necessary. Tourniquets should not be in place for longer than 2 hours, as that can lead to the risk of compartment syndrome, where blood supply is cut off, leading to ischemic injury, tissue death, and amputation. Tourniquets used for more than 2 hours and less than 6 should be converted to an alternative method, like wound packing or hemostatic pressure dressing, as soon as possible. If medics are going to be serving in environments where transport to an emergency department and removal of the tourniquet can be delayed for over 2 hours, they should train in what is referred to as tourniquet conversion, where you take a tourniqueted injury and you turn it into a wound-packed injury, one with a hemostatic dressing generally. Tourniquets in place for over 4 hours were associated in 66 different studies with reduced limb salvage rates and higher mortality rates, compared with a tourniquet time of less than 2 hours. But the mortality rate was still only 7.1%, and the mortality rate from not putting on a tourniquet is 100% if someone's bleeding to death. So, and that's for tourniquets kept on for, 4 hours or more. Okay. Whew. Tourniquets left in place for longer than 6 hours should be left in place and handled by a medical professional with experience with compartment syndrome and managing harmful metabolites that get released back into the body, because just like a crush injury, there's harmful chemicals that build up in the limb, and you release those back into the rest of the body, the person can die. Each tourniquet style has its own release mechanism. Most commercial tourniquets have a place to write on them in indelible ink the time the tourniquet was placed. Do this so you know exactly how long it's been on. A tourniquet is generally taken off by emergency medical services at the emergency department, but EMTs may choose to remove one placed by a medic. They are trained in doing so. The medic should not interfere. Don't fight EMTs and be like, I just put that on there. They know what they're doing, hopefully. Each tourniquet style has its own release mechanism. If a medic takes off a tourniquet they have placed, they need to be aware that bleeding can immediately start again, and may also damage blood vessels to have blood suddenly restored. They should be prepared to place the tourniquet again if the blood starts spurting. Once emergency medical services have arrived, they should be informed when the tourniquet was placed and why, as well as the other information gathered, such as the mechanism of injury and if the person is on medications that impact bleeding and clotting. You can improvise a tourniquet if one is not available. Use a triangle bandage that you fold to about 4 inches wide and 6 to 8 layers thick. They wrap that around the limb twice in the same placement as a commercial tourniquet. You then tie a knot in the bandage and place a stick or rod on top of that knot. Then tie the end of the bandage over the stick in a square knot to hold it in place. You would then use the stick or rod as the windlass, twisting it in circles all in the same direction. Pick clockwise and just keep going clockwise to tighten the fabric around the limb. If possible, they should secure the stick or rod in place once the tension has stopped the bleeding, rather than trying to maintain that tension by holding it in place. The person should still be labeled with the time applied, which, since the tourniquet does not have a place to write it with, this can be done on a piece of tape with a marker or by writing on the person's skin somewhere visible to emergency services. Most medics write the time on the forehead. If you can't write it on the tourniquet itself, write it on the forehead. This is when the tourniquet was put on. Okay. The stick or rod is necessary. In one study using a large cotton t-shirt wrapped tightly around the thigh of a computerized tourniquet trainer, the t-shirt lacking a windlass failed to generate enough pressure in 79 out of 80 attempts. The thing they do in movies where they just use a t-shirt to make a tourniquet and no stick does not work. It is also possible to use a blood pressure cuff as a tourniquet as a last resort in an emergency, but they may lose pressure. The gauge should be monitored to make sure pressure isn't dropping. It may be necessary to clamp the tube that leads from the cuff to the inflator so that air can't leave. Never improvise a tourniquet from wire, rope, a belt, or other narrow materials, as these can cut into a person and cause a second injury. Emergency medical services may also carry special tourniquets for injury to the groin and the chest. Whew. We are not going to get into splints because those are for broken bones that have lacerated, but I'm going to note that we do teach that. Hemostatic agents. Hemostatic agents are substances or materials that help to stop bleeding. It can be necessary to employ them in areas where a tourniquet cannot be used, like a joint, the groin, or the chest. Hemostatic agents adhere to the damaged tissue. Some work by dehydrating the blood, while others work by creating a chemical reaction that stimulates the natural blood clotting process. Some are deployed as powders, while others are gauze dressings that have had a hemostatic agent already on them. We prefer the bandages with a hemostatic agent already on them because the powder can possibly lead to deposits that lead to embolism, and they introduce foreign matter into the wound. The granules can also complicate suture closure. The military uses Celox, Hemcon, and Quick Clot, which may be either granules poured onto a wound or contained on a dressing. My personal preference is for Quick Clot dressings. They're really easy to use, they're really easy to buy. Hemostatic agents are lightweight, they're easy to store, and they're easy to use. And you use them sometimes in what's referred to as wound packing. Wound packing is used in areas where tourniquets are ineffective, such as the groin or when tourniquets aren't available. It should never be done on the chest, the neck, or the abdomen. Do not pack those wounds. The U.S. military employs wound packing with hemostatic agents. Wound packing works by absorbing blood and concentrating the clotting factors, rather than allowing the blood to pass out of the body with the clotting factors in it. It also helps apply direct pressure to deeper lacerated blood vessels, rather than diffuse indirect pressure that isn't effective. Using hemostatic dressings, they can also chemically aid the clotting. The dressing is pushed into the bleeding wound with an index finger. That finger maintains direct pressure on the bleeding blood vessel while more dressing is pushed in to completely stuff the wound. The pressure has to be maintained while it's being pushed in. So like one finger's in there and the other finger or your other fingers are just pushing more in. Does that make sense? Okay.
And so then, like, are you like, after you've removed your finger, are you like pushing it in to fill that space?
Yes,
too?
exactly. And you pack that wound until no more goes in. And then you pile up the extra on top of that wound and you put more pressure on top of that, either by your hand or using a pressure dressing, but really it should be your hand. The thing that they do in movies where they're like, oh no, someone's bleeding to death, I'll just press a bandage on top of it, does not work. You have to actually shove the bandaging in there, packing it in as tightly as possible. And this is when I said you use that lightweight gauze. The stuff I said you don't dress a wound with, you do use for this. The very reason you don't dress a wound with it is that clotting factors stick to it. You want the clotting factors to stick to it. You want it to lay into that lattice and concentrate all those clotting factors where all of that packed in dressing is. Now the medical services, they're going to be who unpack it and stitch up the blood vessel. We don't do that. If you are packing a wound, you are packing it and then holding pressure until EMTs arrive. Unpacking a wound is its own whole messy thing that I'm not going to get into in this. Okay, I will note here that we are at time. I have 2 quick sections left, and it is on treating and preventing infection, and on preventing scarring. It's up to you if you want to stay for them. I don't know if Ruma needs to close, or if you would prefer that we just treat that as another class at some point. I mean, we will eventually have a class on treating and preventing infection. I know it's been long. I didn't get through the information as fast as I want to. It's up to you if you want to go. Okay. Whew. I will note here, clamps. There was a time when if a bleeding artery was spurting, people would clamp it while waiting for emergency services to arrive. It's not recommended. You can't see well enough in the field to actually accurately place that clamp on that bleeding blood vessel. You will probably clamp the wrong thing, not adequately clamp the artery, maybe clamp other vessels and damage them, and it's unlikely that you know exactly how to clamp it to keep it shut. I will note here that one of the times that I have been in a situation where someone severed a spurting artery, my great-grandmother clamped that artery all the way down the mountain to the hospital while riding in the back of a pickup truck that I was not good at driving. I don't know how she did that, and I wish that she had known that tourniquets would have been the better option. But she was a medic who was taught that you never used a tourniquet. And so she didn't. And now, you know, as an adult, I'm going, oh, actually what she did is what you should never do, and a tourniquet is what you should do, but she did save that person's life. Now, she was also a trained nurse, and knew how to clamp an artery. I don't think that's something I can teach any of you. So I'm just going to say that that's not what's recommended. It's what's done in surgery. They'll clamp arteries while they're working on things, but we're not surgeons. Okay. Whew. Wound healing. Most wounds heal on their own, but some of them get complicated. Jagged wounds take longer. Wounds with lots of contaminants take longer. Wounds to larger areas of the skin, like if it takes off a lot of skin, those tend to get more complicated. Wounds on the lower extremity tend to be more complicated to infection than upper extremities. Wounds in areas with high concentrations of bacteria, the perineum, the underarm, the mouth, the feet, the nails, they're more likely to become infected. Wounds that were delayed in being cleaned and dressed for several hours are more likely to be infected. Wounds that are more than 5 hours old have consistently been found to grow way more bacteria per gram of tissue. Wounds from impalement are more likely to become infected and will be addressed in later class. Wounds from bites, again, pressure injuries on people who are immobile, such as bed sores, are more prone to infection. And again, that's a different class. Open wounds that are being left to heal from deeper within so that they can adequately drain, like ulcers, are more prone to infection. People who suffer from certain medical conditions often have complications with wound healing. These include, but are not limited to, advanced age, diabetes, alcohol abuse, acute uremia, hypoxia, severe anemia, peripheral vascular disease, malnutrition, Ehlers-Danlos syndrome, advanced cancer, hepatic failure, and cardiovascular disease. People who have malnutrition, zinc deficiencies, vitamin A deficiencies, and vitamin C deficiencies may suffer from delayed wound healing and increased risk of infection. Very, very common in the unhoused, not only to become infected because there isn't a place to adequately clean their wounds, but also because of malnutrition. Wounds in children may be complicated because they pick at them, they remove their dressings. Wounds on people with certain mental health conditions and or developmental disabilities may be complicated, again, because they pick at them, they remove their dressings. People on certain medications, they also have delayed wound healing or be at more risk for infection. These include, but are not limited to, immunosuppressants, corticosteroids, non-steroidal anti-inflammatory drugs, penicillin, colchicine, I think that's how you say that one, anticoagulants, and antineoplastic agents. Preventing infection. Most prevention of infection comes down to education. People need to be taught how to clean their own wounds. They need to be taught that pressure and friction on healing tissues disturbs them, reopens wounds, and causes infection. For uncomplicated, simple laceration, the first dressing change should be the 1 or 2 days after a wound is treated. It's then cleansed of any of the dried blood and wound exudates using sterile water, sterile saline, or wound wash. The dressing should be changed every 2 to 3 days until the laceration is healed, and during that time is when you're monitoring for infection. Okay, signs of infection. I'm skipping a few things that really just repeated and stressed what we'd already said. The signs of infection may not be present for several days after a wound is created in the skin, even though the harmful microbes may have entered the body at the time of injury. It takes time for those microbes to multiply and end up becoming an infection. The signs are excessive pain. Most wounds don't hurt that much, so a lot of pain is indicative of a problem. Pain larger than the wound. It makes sense for the abrasion, the avulsion, or the laceration to hurt directly on the wounded tissue, but if the pained area is much larger than the wound, that's a sign of infection. Swelling, discharge, especially if it's cloudy, it's yellowish, it's greenish, and especially if it smells bad. Redness that extends beyond the wound margins, red or pink streaks adjacent to the wound, that's very serious, do not ignore that. Lymph node swelling, especially near the wound, fever, shaking, joint pain, and hypotension, low blood pressure. Natural remedies for infection. What actually works? Major infections need to be treated by medical professionals. Minor infections can sometimes be treated by cleaning and irrigating the wound following the steps already detailed in application of an antimicrobial ointment or salve. Raw honey actually works. Honey has antioxidant, antibacterial, and anti-inflammatory properties and can be used as a wound dressing to promote rapid and improved healing. It is used in wound care centers and burn centers around the world and has been in use for wound healing for thousands of years. Honey has an almost equal to slightly superior effect when compared with conventional treatments for acute wounds depending on the treatment. Calendula salve or ointment, so long as it was created in a sterile fashion and does not itself contain bacterium or mold. A 2016 research review of in vitro studies found that calendula stimulated collagen, was antimicrobial, and had anti-inflammatory properties for wounds. Dragon's blood resin is the antimicrobial resin of various plant species, including croton species, Pterocarpus species, Daemonoorops species, Dracaena species. It's sold as dried or liquid resin, although it is the 100% liquid resin that we recommend for wound treatment. Bottle's about $28. A 2021 review found that studies verified the antimicrobial properties in dragon's blood against nearly all bacteria and fungi that it was tested against. The main one it showed no effect on was Salmonella enteritis. It not only is a treatment for small lacerations and abrasions, but also for ulcerations and bed sores, which I don't know if you know this, but it's really hard to treat bed sores, so finding something that's effective against Staphylococcus and Streptococcus is like a really big deal. Anyway, what we do not recommend: rubbing alcohol. It dries out the wound, it damages the healing cells. Witch hazel tincture. This dries out the wound and damages the healing cells. It also isn't an effective antimicrobial for an infected wound. And it occurred to me right before class started that there's one that I don't have on here, which is called Bone Set or Comfrey, which a lot of people like because it's a blood clotter. Like you apply it to a wound and it causes clotting. The problem is that it also tends to trap infection. So if there's an infection, it can't get out. So that one is not recommended personally. Also, you shouldn't take it if you're at risk for kidney damage. Pain management. Pain can be managed with cold compresses or warm compresses, though they should not be placed directly on the healing abrasion or laceration, but rather in the surrounding area. White willow bark, Salix alba, is an analgesic with anti-inflammatory, sedative, hypnotic, and febrifuge properties. It's been used to treat pain for thousands of years. It is the basis for aspirin. We get aspirin from this plant. That's where we got it. It's a phytochemical. Willow bark is possibly safe when used for up to 12 weeks. Salicin, the phytochemical primarily responsible for its pain-relieving effects, can be used by adults in doses of 120 to 240 milligrams of salicin by mouth daily for up to 6 weeks. It takes approximately 1,360 milligrams of standardized willow bark extract to contain 240 milligrams of salicin. Willow bark's level of salicin varies wildly from plant to plant, and even through the seasons, and so for that reason we have listed the dosage of the standardized extract rather than a hot water infusion. You can just drink white willow bark tea. It's so bitter. I just want to warn you, it's so bitter. The extract is much easier to take and the dosing is much more precise. It might cause diarrhea, heartburn, and vomiting in some people. It can also cause itching, rash, and allergic reactions, particularly in people who are allergic to aspirin. If you're allergic to aspirin, don't take the plant source for aspirin. Seems silly to say, and yet I have met people. It is contraindicated for people with bleeding disorders, clotting difficulties, kidney disease, or who are on blood thinners, diuretics, or other salicylates. People should check their specific contraindications. I also recommend valerian. It's a relaxant sedative nervine. It calms the nerves, antispasmodic plant that can help injured people relax and sleep. Valerian has often been used by adults in doses of 300 to 600 milligrams, approximately 2 to 3 grams of dried herbal valerian root soaked in 1 cup of hot water for 10 to 15 minutes by mouth daily for up to 6 weeks. It tastes and smells like sweat and dirt. It's not particularly pleasant, and for some reason Ian adores it. It can cause drowsiness, gastrointestinal upset, headache, and heart palpitations in some people. People with ADHD may actually develop insomnia and overstimulation from taking it, rather than actually being relaxed by it, so it doesn't work for them. It should not be combined with GABAergic agents, barbiturates, other sleep medications, alcohol, surgical anesthesia, or medications that are broken down in the liver. You need to check your specific contraindications for each person that you are given these. Whew, scarring. As we said, all lacerations will cause a scar. The function of a scar is to repair the wound. If the wound didn't scar, then it never healed. Remember that a healing wound, once closed, only has 5% of the strength of normal skin. Recent wounds are more likely to scar if they are exposed to direct sunlight. Keeping a healing laceration covered can help prevent a visible scar, so can the use of sunblock once the wound is healed enough to have a topical sunblock applied over it. The wound is at risk for hyperpigmentation from the sun for a year. It doesn't just stop after a couple of weeks. For a year, a fresh scar should have sunscreen applied to it. And honestly, you should be wearing sunscreen anyway. Some wounds are more likely to visibly scar, including those are large, jagged, or on areas that move a lot with a lot of those skin tension lines that we talked about. A lot of dynamic tension, more scarring. Wound infection can also make it more likely to scar. Skin on the back, chest, upper arms, and lower extremities is also more likely to scar. If sutures or staples are left in place for longer than 7 days, especially if longer than 14 days, they are also likely to leave scars, which is where you get those scars where it has like the dots on either side. That's because the sutures were left in too long. Some people produce excessive scars, which are called keloid scars, keloid, which is super fun. It's great. There is no chemical method to eliminate scars entirely. Care can be taken to try to prevent them. It is better to try to prevent a scar from forming if possible. It's going to forming in an exaggerated fashion is better to say, by keeping the wound clean and moist and preventing infection. There are many, many ointments, dressings, and herbal preparations that people claim can reduce scarring. The small number of clinical trials performed so far has not found any significant benefit in any of them. No, not even vitamin E oil. Nope. The main part of any of them that actually improves how a scar forms is the moisturizing aspect, because wounds kept moist while healing scar less visibly. It isn't the vitamin E and vitamin E oil that is helping the scar not be as gnarly. It's the fact that the wound was kept moist. You could just use any oil. You could use olive oil. I don't know if any of you have ever been pregnant. A midwife will tell people rub olive oil on their belly to help prevent stretch marks. That works because they're moisturizing the skin, not because it's olive oil infused with vitamin E or whatever else. Okay. Don't spend a lot of money on expensive ones. Not a single one has been tested and found to be really effective. There has been a significant body of research on the use of massage therapy on scar tissue as it has formed during the reconstructive phase of wound healing. Called scar massage, there is evidence that it can reduce the pain of scars, increase their pliability, decrease thickness, and reduce itchiness, as well as reducing the tendency of the scar to stick or adhere to the underlying tissue, which can cause problems. This is essentially done by encouraging the collagen that forms the scar tissue to form in an orderly fashion, crossing the wound in parallel rather than being formed at more or less random angles, which the body can do. It can just be like, I'm just going to form collagen wherever the heck I want to. You just kind of encourage it to lay down where you want it. There are surgical techniques like Z-plasty and dermabrasion, and non-surgical techniques like cryotherapy, certain corticosteroids, laser therapy, that can alter scar appearance effectively if a person's really concerned about it. They're all expensive. Most of the time, unless the scar is impeding movement, insurance isn't going to cover it. So preventing a scar from forming badly is better than trying to fix it once it has. Okay, we did bring a tourniquet. Don't turn it off until I ask if there's questions people want on camera. If you all want to see how you use one, and what we'd like to do is one of our classes next month, we want to actually teach you how to do some of this with your hands. We're going to get a laceration model. We already have a wound packing model. And actually show you this is how you do it and give you a chance to do it with your hands. I'd like to teach you all how to apply Steri strips, square bandages, how to use a gauze pad, how to actually apply ointment without getting it into the skin, and if we feel up to it, maybe even how to use Dermabond. But we also are trying to get together a lot of medic supplies before a big event here. So I don't want to run through too many of our supplies before we actually need them potentially at the end of the month. So if you all would like to donate supplies or bring them with you when you come to learn, I will make a list available, get it to Ruma, or you all can reach out and say, hey, I want to donate, what should I bring? But the basic answer is it's going to be like Steri strips, zipper wound closures, gauze pads, gauze rolls, the very things we talked about in this class so we can teach you how to use them appropriately. Okay, while we are still recording, does anyone have any questions or comments or snark you'd like to share with the people who watch the recording later? I know I just threw a lot of information at all of you, and there's probably a lot bouncing around and you're going, I don't even know what question to ask. So please keep in mind that you can always email us. We can be reached at staff@sanctumofthecraft.org, or you can find me on Signal under the name Akima Shields, and ask me questions there. And I'm always happy to answer it, and if I don't know the answer, I will try and look it up. I have one last thing to say, which is we talked a lot about referring to emergency medical services. Please be willing to call 911. Sorry, I actually have one more. There is a full bibliography for this class. The problem is that I think I need to go through it and highlight the books I don't recommend. Because a lot of this was based on me reading those books and being like, what the fuck, no. Don't do that. Why would you instruct someone in that? And they need to be in the bibliography because I based the incorrect information that I'm citing on them. So what do you say? Should I highlight the ones I do recommend in green and the ones I don't recommend in red? Okay, that is how I will do that. Because I do believe in having a full bibliography, and I'd like these all to eventually be fully cited in line as well. But, whew, okay, now you turn off the recording.